pupil reflex central is the eyes moving in full directions, whether there is a pseudo strabismus or there is a true strabismus. The infants would be following, making eye contact the moment they come into your clinic, and you can follow their faces and see how he smiles and imitates you. The toddlers would be moving and following the objects. They may be picking up different things in and around your clinic, which will tell us that the vision is good with the child. Once the child is verbal, then you have a visual acuity screening with appropriate optotypes. So the most easiest way, even if you don't have anything at your clinic, if you can occlude one eye and the child has started crying, then very likely that the eye which has been occluded is the good eye. So this is the simplest test that can be done at a screening as a screening procedure at any place without any objects with yourself. But once you have a teller acuity cards, you can use them and find that whether the child is looking at the interesting strips than rather than the gray background. And in the small peephole, the observer will be observing the eye. And by the location of the strips, you can make out whether the patient is observing the strips. And if he is, then you can get a approximate value from the teller acuity cards. Visual potentials can be used for seeing the EEG recording from the occipital lobe in response to the visual stimuli. There are multiple types: flash VEPs, pattern reversal VEPs, and sweep VEPs. And VEP is like when you are very much worried that with the optic nerve is at fault, then only we go for a VEP, or we have a HIE patient who is not looking at the objects, is not fixating and following, and then you go for VEP. These are simple Leo gratings which can be shown to children, and very small infants would be looking at the strips. The Cardiff acuity has a principle of vanishing optotype, so the pictures are of same size but decreasing width of the white space, and the acuity is determined by the narrowest white band for which the target is visible to the child. The child would naturally look at the target figure rather than a blank end of the stimulus. It's important to examine the fundus because that would be giving us a lot of reasons why the patient is not looking at the light. So this is a picture of a battered baby syndrome, which happens and the child has multiple hemorrhages. So the advanced screening procedures are the photo screening, automated refractometers, VP screening, and the retinal biofringencies. Importance of pediatric vision screening is because of amblyopia. Amblyopia affects almost 5% of the population, and in the first 4 decades of life, amblyopia is the most important cause of loss of vision. Therefore, we have a window period from which we can treat amblyopia. Screening is very much important. It will also prevent fatal disorders like retinoblastoma. This is the periodicity schedule of visual assessment in children. So most of the time we would be looking at the child at 6 months of age, at the newborn stage, then at the 6 months to 12 months of age, then 1 to 3 years, 3 to 5 years, and 5 years and above, we would be looking at the child yearly. Age-specific screening in children, the red reflex is the best to see, and the fundus examination. Buchner's reflex can be seen by any doctor, even a pediatrician can find out whether there is a problem, and it is a very handy tool. Leukocoria is an emergency, as we know: cataract, glaucoma, PHPV, retinoblastoma, retinal detachment. These would be the problem. So coming to challenges during COVID times is the children are intimidated by the mask faces. There is difficulty of examination of the child from a distance, and the waiting time and the requirement for GA procedures is a problem. So what are the guidelines for prescribing refractive error in children? So in hyperopia, you would be prescribing glasses if it is more than 3.5 in one or more meridian at 1 year of age and upwards. And at 4 years, it will be more than 2.5, and it would be 1.5 at 2 years. For myopia, myopia will be more than 2 point, for cylinders it would be 2.5 at 15 months of age, more than 2 at 2 years and onwards, 1.5 at 4 years and upwards, and oblique astigmatism has to be corrected. For myopia, it has to be more than 5 diopter
1
during the
minute
age
left, ma'am.
first year and -2 from 1 year or when the child is walking. 4 years onwards, it may be -1. And anisometropia has also always to be corrected if it is more than 3 diopters, and within 1 to 3 after 1 year of age you need to correct it. Aphakia and pseudophakia, the children have to be corrected with a overcorrection of +2 and +3 diopter, and after 2-3 years you give bifocals. Any anisometropia of 3 diopter or more at 1 year or like age is a problem and therefore needs to be corrected. Thank you.
That was well on time, Anuradha.
Thank you, ma'am. Thank you.
We'll take the questions at the end. Of course, there may be questions. I think the participants will be putting the questions in the QA box. I think, is it true, Nikhil? So then maybe the participants will put the questions in the QA box and we can take it later. So the next talk is by Dr. Swati Fulgile. She's going to speak on amblyopia management beyond patches. Dr. Swati?
Yes, ma'am. Can I share my screen?
Yeah.
Are my slides visible?
Yes, ma'am. Just put it in presentation mode and you're ready to go.
Right.
Nikhil, may the questions be put in the Q&A box?
Yes, ma'am. From the site, that is the website, the questions are going to be put in the Q&A from the AV team itself.
Okay.
Okay, thank you, DOS, for the opportunity. I would be talking about management of amblyopia beyond patches. But as we all know, patches indeed are still till date gold standard. So I'll be just briefly talking about patches also and the other therapies that are upcoming. So as we all know, amblyopia is unilateral or bilateral decrease of vision where there is probably because of patterned visual deprivation or abnormal binocular interaction for which no cause can be detected, and if treated on time, it can be treated or is reversible. So there are various types of amblyopia which we already are aware. Strabismic amblyopia, which is more commonly seen with esotropias. Ametropic amblyopia, which occurs when there is bilateral significant high refractive errors. And isometropia, when there is a difference of refractive error between the two eyes. And of course, visual deprivation amblyopia, which is most difficult to treat. So the management of amblyopia depends on the early identification, evaluation, and intervention, especially in a critical age group because of the presence of cortical spasticity, which is generally till the age of 9 years and decreases as the age increases. It also depends on the various factors like age of the patient at which the treatment is given, the duration of low vision, refractive error, type of refractive error, type of amblyopia, and of course, most important, patient compliance. So earlier when the goal was to achieve the equal vision in each eye. So the idea was to identify the cause of loss of vision, correct the refractive errors adequately, and preferentially stimulate the amblyopic eye. But now the goal has changed from achieving equal vision in each eye. The goal has now changed to achieve the binocular vision so that both eyes are equally stimulated. So earlier we had this optical correction, occlusion therapy, penalization, active vision therapy, and pharmacotherapy, which was kind of given, which we used to practice for our amblyopia patients. But now it has changed, and now the active vision therapy has come in big way, and it has become the major way of treatment for the amblyopic patients. However, all said and done, the best, the optimal optical correction is the mainstay of amblyopia therapy. Unless you correct the patient for a refractive error, whatever amblyopia therapy we give may not work. So these are the guidelines that have been published at in IGO. So after the pediatric ophthalmology expert group consensus, and these guidelines provide us how and when we should prescribe the refractive corrections. Again, as I said, that after the optical correction, the occlusion therapy still remains the main gold standard for the treatment, but its success rate tends to decrease with advancing age of the time. of the child. So there has been whole debate of total versus full-time, total versus partial occlusion and full-time versus part-time occlusion. But various studies have shown us, pedic studies have shown us that the part-time occlusion may be as good as full-time occlusion, specifically in mild to moderate myopia. Then maintenance of occlusion is also important. So we should not abruptly stop the occlusion. We should actually taper it over the period of time so that the rate of recurrence is less. There are various factors which are responsible for this recurrence: age of the patient, larger visual recovery, better visual gain after the cessation of therapy. Younger the age of cessation of therapy, more is the chances of recurrence, and strabismus and mixed myopia are more prone to recurrence as compared to anisometropic myopia. The third is penalization, where we want to penalize or we want to punish the good eye so that the worse eye can have an advantage. So it can be done optically by giving high plus correction, or pharmacologically by using atropine, cycloplegics, other cycloplegics, and it is useful for moderate degree of myopia, but may not be so useful for severe myopia. Pharmacotherapy, drugs like levodopa, citicoline have been tried, but they have had very short-time improvement, and the improvement is sustained only till the drug is maintained. Otherwise, the improvement is, after that, the improvement ceases to occur. What is the mainstay of myopia today is active vision therapy, where we give some kind of active vision, when we give some kind of task to the patient so that the patient's mind is involved in that task, and the patient's cortical stimulation is also occurring during that time. So video game is one such form of giving active vision therapy. So it causes a re-education of myopic pathway. By that I mean visual pathway, and there is an interaction between the cortical pathways. So active vision therapy can occur either in monocular video games or dioptic active vision therapy. So we have this study done at our center. We evaluated the role of monocular video games, and we found out that in the patients who had both combined occlusion therapy along with the monocular video games for a period of 1 hour or so, we found that the patients who received the combined therapy had better improvement in visual acuity as compared to the patients who received only the occlusion. After monocular video games, there is definitely a role of dioptics, where we stimulate both the eyes but in differential manner. So each eye is presented with a different image independently, and the brain is forced to integrate this image to form a single binocular vision. The main advantage of this therapy is to have the binocular viewing. So it stimulates the cortical cortex for the binocular viewing. So in this study, which was done at our center, we had this 60 patients, each divided into 2 groups of 30 each, where we asked them to play with this Tetris game, and where and the other group was given part-time occlusion. So we found that the best corrected visual acuity in both the groups was significantly improved at 3 months, and it was comparable at the baseline and as well as at the final outcome measure. But the near stereo acuity was definitely better in the game group as compared to the occlusion group, and also the contrast sensitivity was better in the game group. But we, at the same time, interestingly, we found that only 38 to 40% of children less than 10 years were compliant with game, while the older children were more compliant with game, and vice versa. The younger children were more compliant with patching, and the older children were less compliant with patching. So to conclude that the management of myopia, the first and the foremost cause is to rule out the organic cause of loss of vision, give the proper cycloplegic refraction and optimal optical correction. If it's an anisometropic, strabismic or mixed myopia, you have to use continuously glasses. Occlusion therapy and active vision therapy can together be combined to give, a proper treatment for these patients. If it's an ametropic myopia, no occlusion is required. You can simply prescribe the glasses and there may be improvement. After the improvement has occurred, it is important to maintain the proper occlusion and taper it gradually. If no improvement occurs, the most important thing is to ensure compliance. Thank you for your attention. Thank you.
That was a very nice presentation, Swati. Excellent. I think it's so difficult to keep questions at the end. Actually, anyway, it's a habit.
One by one.
Okay, let's write it down. And I think Dr. Jaspreet, you want to introduce the next?
Yeah. Yeah, so after that nice overview about amblyopia, which has obviously tickled our brains to, and we have a lot of queries, I mean, which will be taken up in the end. I'll request now our next presenter, Dr. Shruti Nishant, and who will be speaking on digital eye strain. Over to you, Dr. Shruti.
Thank you, sir. Thank you for the kind introduction. I hope you can hear me.
Yes,
Yes.
loud and clear.
Okay. So can you see my slides as well, sir?
Yes.
Okay. So today I'm going to be talking about the elephant in the room, and that is digital eye strain. So yes, it's quite obvious that we do have an elephant, and that elephant is quite cumbersome to deal with, and it's affecting all our lives, including mine. But digital eye strain has been affecting a lot of people, but a lot of studies have been done in a very narrow perspective. And considering that this disease is affecting overall spectrum, we need to look at it from a broader view. And that's what I'll attempt to do it this time. So we define digital eye strain as a spectrum of clinical vision related and muscular symptoms perceivably resulting from prolonged and continuous use of visual display terminals, and such as smartphones, televisions, tablets, etc. So we do know the smartphone market has penetrated quite deeply, especially in our country, with almost 95 to 98% of people ending up with smartphone users, especially the younger generation. The prevalence of digital eye strain is anywhere between 22.3 to 39.8, and almost 50 to 90% of all computer users experience some symptoms of CVS. But when it comes to COVID, we do realize that over the past 2 years, things have not have changed a bit. The DESK-1 study was an interesting study published in India, where they studied 261 students using the CVS questionnaire. They found out that during the COVID era, the mean duration of digital devices had jumped up to 4 hours, and almost 40% were using digital devices more than 5 hours in COVID era, as compared to 1.8%. And in this group, they found the prevalence of some form of a digital eye strain was 50% almost, and the risk factors was an older age group, male gender, smartphone use, more than 5 hours of digital devices use, and mobile game use of more than an hour a day. Now, when it comes to the ways it affects our body, it can be ocular or non-ocular. Of course, ocular will be the binocular vision anomalies, the dry eye, and of course, retinal corneal damage that we'll talk about. The non-ocular are mainly the musculoskeletal issues. We do see patients coming with neck pain, back pain, carpal tunnel syndrome, dermatological conditions such as seborrheic dermatitis, eczema, rosacea, and thromboembolic risk because of, pretty much a stagnant lifestyle. Now, the symptoms we do all know: watering, redness, burning sensation, blurring of vision, diplopia, color sensation lost. But what is important is to look at the signs that are associated, and we do have quite a lot of evidence that points to both accommodation as well as divergence of families being affected. It causes significant accommodation lag, decreases the accommodative amplitude and decreases the facility, causes a fusional vergence effect and decreases the NPC, and also sometimes this results in ocular deviation with a shift to exophoria. And I'll be talking about another condition in the next slide. Of course, it also causes a blinking and ocular surface issue by decreasing the blinking rate and amplitude, and of course decreases the tear volume, stability, and the composition, and insufficient data regarding corneal staining. Now, I'd like to put it as two groups. If the eyes are lazy, then then the subjects end up having some form of accommodative lag or convergence insufficiency. But if they are kind of hyperactive, then they end up having some form of accommodative spasm, or a new entity that we do seem to see a lot lately, that is acute acquired comitant esotropia. I think the DESK-3 study has reported around 8 patients that they've seen during this lockdown. And I personally have seen 3 kids. One was a very young kid, around a 3-year-old, who's been using almost more than 5 hours of digital devices. This was an 8-year-old, and this was quite an older person, like she was around 25 years old. She required surgeries, whereas the other 2, one of them recovered on their own, and the other one I'm still waiting for a 6-month follow-up. So we did a study to assess pre and post vergence in accommodation parameters after half an hour of monitored reading on a smartphone device to see what affects it. And we did it on 46 normal subjects, and we used a normal digital LCD display with a bright illumination with a font size of N6 at 40 centimeters with 80% contrast, and gave them a story as a reading material. And we did find that there was significant lag of accommodation after the 30 minutes of smartphone reading, which was seen from the NRA, PRA, and the MEM retinoscopy. We did find that there was significant drop in the near point of convergence and as well as accommodation. The accommodative facility dropped as well. And from this, we could conclude easily that even 30 minutes of continued smartphone use tended to produce significant changes in the eye system. And of course, we do know that dry eye as such is a deleterious effect that is seen along with digital eye syndrome, and it's part of an inflammatory cycle that is beyond the purview of our topic today. Now, how about blue light and retina? There's so much talk about this short wavelength, high energy visible light, which is in the spectrum of 400 to 455 nanometers. And they say that the displays that we use tend to have this high energy visible light that can cause direct damage to the retinal cells and photoreceptors. And they do find that the blue light tended to have more damaging effect than the other two primary colors. And these are all in vitro studies that have been done, and not much of clinical data available on that. In all this jazz that we talk about the retina, we seem to miss the cornea, and we know that there's enough evidence to suggest that cornea also is affected because of increased reactive oxygen species, decreased cell viability, and damage to the cells directly. So I evaluate digital eye strain by using a CVS questionnaire and sometimes a CIS score. We do the Sherman's, Teeth Beauty, tear meniscus height, corneal staining, and of course a good binocular vision evaluation. We do the RANDOT, Worth4 dot, RA, Flula, Prism bar, and the flippers. Coming on to the management strategy, I think the first thing that I would tend to do is restrict the near gadget, because there are several studies that show that more than 4 hours or 5 hours of continuous work is detrimental. And of course, visual hygiene plays a very important role. We have to advise them to wear bigger glasses, wear glasses, or if there is any refractive error, choose bigger screens, bigger working distances, frequent blinking, sitting near a window with good natural ambient lighting, the 20-20-20 rule, which I'll be talking about again, and a good ergonomic posture with monitored outdoor breaks between classes for children, and adjusting the image parameters such as resolution, text size, contrast, and luminance. Now, there are several studies that have suggested that 90 centimeters is a good distance to keep, and a downward gaze angle of 10 degrees with a good blink rate and the presence of humidifiers in the room tend to add to the moisture in the eyes. Artificial tears are definitely helpful, and then they make a big difference. How about low power convex lenses? There are several studies, especially the CLETA study, which said that 0.5 to 0.75 diopter lenses, especially the 0.75, tended to provide really good help when it comes to the speed of reading. 1.25 didn't fare too well though, so 0.5 to 0.75 definitely helps. Clinically, I don't think blue light blocking lens has good enough evidence. The two studies have been done, both have proven that blue light blocking really doesn't help much when compared to neutral density filters.
1 minute left, ma'am.
Yes. So vision therapy is also definitely a viable option when there is an accommodative lag or some parameter in the binocular vision assessment. Sorry. We did a study on the 20-20-20 rule where we studied 20 to 25 age group, 25 student volunteers, and we split them into 4 days. Printed text versus smartphone video. We took a 20-minute break in between, and one group which had no break in between, the same parameters, and we found that the 20-minute break group improved convergence parameters with no significant difference between printed text and smartphone use. So yes, the 20-20 rule works. So this is my final slide, the take to desk message. Take a good history with the questionnaire, especially a serious questionnaire, evaluate TB and provide like artificial tears, lenses and vision therapy, and of course, never to forget the lifestyle and the ergonomic advice. I thank Dr. Rohit Shetty and DOS for giving me this wonderful opportunity. Thank you.
Thank you, Dr. Shruti. I mean, that was it's a very important topic in the present era where most of the children are having virtual classes. So, I mean, a lot of things need to be told to them, and how to counsel them, and educating them on the proper use of the screen is very important, especially the parents, I mean, for these young children. So anyway, it was a very nice talk, and obviously a good learning points as well. So I think I'll request Dr. Aditya is here. He the moderator. Yes, you can moderate. Go ahead, please.
So our next talk is by Professor Monica Chaudhary on non-strabismic binocular vision disorders. Ma'am, over to you.
Thank you so much. Thank you, DOS. Thank you, Dr. Rohit, Honorable Chair, and the panelists here. I think one of the best things that has been is including an optometrist into this talk, because I feel non-strabismic binocular vision anomalies need a lot of evaluation, and it is the optometrist who can identify while these refractions are done and can be co-managed very well. So I'm Monica Chaudhary. I'm of course an optometrist, and we all know non-strabismic binocular vision anomalies include the accommodation anomalies, convergence anomalies, and of course amblyopia. Dr. Shruti has also been talking, she's just briefed a lot of things about it and discussing. We do agree the digital screens have led to all this, and these anomalies are much more. Of course, not going much into the details about these nomenclatures, we have 4 types of accommodation anomalies: insufficiency, ill-sustained, ill facility, and spasm, and of course convergence. Major 2 ones which I would say is the insufficiency and the excess. So So non-strabismic accommodative and vergence binocular anomalies, they affect what? We'll come across patients who will complain about clarity, binocularity being a problem, impaired comfort, and efficiency of visual performance, especially the near task such as reading, writing, and computer-based work is performed. We're especially going to be talking about children here, and the prevalence is very, very high in children. And it is in the study which was seen last, it was seen as 28.5 to 31%, which is described by one of the studies, but recent only literature has not proven it, but it is said that yes, it would have been much, much higher, especially considering the digital strain and the COVID era. So the symptoms most of the time children would come across are, they would come across the blurred vision for the task, headaches, lot of comprehension, avoidance of work, watering, and sensitivity to light. All this impacts the learning of the children. They have been very clearly defined that the visual demands of these are much more, and the children, it's impacting their studies. It is the convergence and the accommodation anomalies. Convergence insufficiency has sometimes been correlated to the attention deficient hyperactive children, strong correlation, and they have been also been misdiagnosed as binocular vision anomalies. Down syndrome and specially abled children, they need special care when we talk of accommodation convergence anomalies, and convergence insufficiencies can impact the stereo acuity also. Dr. Shruti has already spoken a lot about increasing digital screen and how they have impacted and had led to further increase in these accommodation binocular vision anomalies. So another thing is that when we talk of convergence insufficiency, we usually do the near point of convergence test clinically most of the cases, but that does not mean that it does not signify having a normal NPC or having an insufficient. It could be related to an accommodation anomaly, and there are a series of tests which should be done to find out, just not the NPC. Let me just quickly take you through one example. This is 12-year-old male child with 6/6 vision. Of course, dry refraction told us he's hypermetropic. He wouldn't accept anything. But when the near NRA was done, and on NRA we found that it was plus 2.75 which he needed, which means high amount of lag. Fogging was further done, and finally the refraction comes out to be 0.75. So this patient was forced. So this was accommodation anomaly which was being missed out just by taking a subjective acceptance or refraction. Another example, in a child who just recently came with jumps from 0.75 to 1.75. Again, his relative accommodation, negative relative accommodation was very high than the normal. We fogged and the refraction was just 1.25. Maybe a duochrome test done by the refraction could have also told us that we are overcorrecting. So all the near visual demands have to be assessed. The CI survey forms help a lot in detecting these accommodation and convergence anomalies, and one must clearly focus on the complaints and do not miss these children. There is a battery of tests if one has to really identify these accommodation anomalies and convergence anomalies, which begins with cover test, NPC, NPA, ACA ratio, fusional versions, positive, negative, then accommodation, MEMs, and all these kind of accommodative fusions and version anomalies. There is a sheet chart which should be filled if we have to really diagnose. But the minimum tests which have been said so in a community setup, 3 things: NPC with red-green filter, not the pen push-up, the monocular accommodative facilities which can be measured with the +-2 flippers, and assessment of phorias can clearly tell you, yes, there is something wrong in having either these NSBVAs. So NPC itself does not reflect convergence insufficiency. It could be many anomalies. I'm skipping over these 4 anomalies and discussing much of it, but we know once we have a complete battery of tests, then only we'll be able to define what kind of accommodation anomaly is it and what kind of convergence insufficiency, excess, and correlate with the phorias. So it depends upon the therapies when we give. Refractive errors have to be very well managed, and that's where optometry, a good optometrist is required, because it correlates to the accommodation factors. There are a lot of vision therapies which are even those home-based therapies. It's a scientific battery of tests, not the conventional synaptophores and pencil push-ups. They are historical now, and we have these computer-based digital screens which were already discussed, which are more popular and more scientific. So the principle, the objective is not that we just relieve this patient for a short term. He has to be continuously sustained, because the digital screens won't go off, the near work excess won't go off. We have to manage not with this just short period of therapy, but you have to continuously manage and sustain them by maintenance therapies also.
1 minute remaining, ma'am.
Yes. So the band study is actually the normative data which has been given in for the Indian, and we can compare it. And we myself as an optometrist run through certain courses. One such course is on non-strabismic binocular vision, where Dr. Rizwana and Gayatri Prabhu are the faculty. Any of your optometrists whom you feel are interested, it's almost an 8-week course, but an online course. And this is how we train, with all the videos and modules taken up into it. I'm sorry, my black part of the screen is visible here. So that's all from my end. Thank you.
Thank you, ma'am, for that very informative talk, which has converged all our divergent views on the binocular vision disorders. Our next talk is by Dr. Jethani on pediatric myopia, intervention options. And I'm sure we're all looking forward to this talk. So are you there?
Yeah. Should I share my screen, Aditya?
Please do, sir.
Sure. So should I start? At the outset, I would really like to thank DOS for this particular opportunity, and Dr. Rohit Saxena. This is something which we started years back, and I think now it is a full-blown field. We did have a myopia control clinic, and I know Shruti also runs a myopia control clinic, and more people are now moving towards that. Okay, so why is myopia being discussed when we know that the treatment is quite simple, and since years altogether we know that we just have to do glasses, especially in pediatric myopia. So why we are discussing it? Because of one of this very nice papers which was published in 2010 by Holden et al., where he could extrapolate the data that by 2050 there would be a projected increase of almost 52% in myopia and almost 10% in high myopes. And this is taken from his paper, and this is just a demography of who and where they will be affected. We all know that I would just skip these slides. And this is a good slide which we use when we talk with parents as to what is the risk of myopia, and it increases if parents have myopia. This has now been established by multiple papers that if one of the parents is myope, there will be almost twice the risk of child having myopia, and if both the parents are myopic, the risk is 5-fold. And this is another good study. I would be summarizing. Okay, so the key messages from all these data search and data research is that if parents have myopia, kids are more likely to have it. Outdoor activity does make a difference in the growth of eyeball and therefore in myopic progression. These are all now published, documented, scientifically proven facts that near work and amount of light does result in myopic progression. Height increase has also correlated with the growth and size of eyeball, and it occurs 2 years before the height spurt. This is from the Singapore study. And this is a wonderful article. All the wannabes people who want to start a myopia control clinic should go through this, because it has listed all the risk factors for myopia progression in school-going children. A wonderful article. I think some of the references are of Dr. Rohit Saxena, also from RP Center. And this also has been established by multiple studies that there is no direct evident role of vitamin D. It is more about spending the time outdoors and less about straightforward vitamin D treatment. And this brings us to the interventions that are now being popular across the globe. The story basically, the atropine was being used for control of treatment of progression of childhood myopia since a very long time. Why ATOM 1 study is an important landmark is because these people did a randomized control trial of double mask placebo control trial between one eye and other eye was on placebo. My point is that this is a very robust 400 Singapore children study. For a period of 2 years, they were using atropine 1% in one eye and placebo eye drops in other eye. And they found that atropine did work, and you can see that it reduces the progression by almost 77%. That is huge over a period of 2 years. We did a longitudinal study since 2013, and we were using 0.01% when it was not available commercially. Now we are fortunate that it is there in the market since 2016, and since 1.5 years it is now DGCI approved. So it is very easy now that it is commercially available. The only important thing is that we should document the progression of myopia, both in terms of psychophilic reflection and in terms of axial length. This was from the study which we presented in 2018 at AIOS, and it shows that once you start using atropine, the curve starts flattening compared to when you don't use it. This was another study which we did to see the compliance, and we found that almost 14% of the patients do not comply with the usage of drops. This is a very small sample size, but this was done within a month so that we can control the confounding variables. And as has already been discussed by Shruti about eye strain and a wonderful study which is published on digital eye strain, we did a small retrospective study to find out what was going on in terms of children who were not using atropine and were myopes. We tried to compare the data between the lockdown and before lockdown, and we found that the jump in myopic progression was almost twice. And this was when the child was already growing, and the jump was almost twice what was there prior to lockdown. This was a small video which we made for schools, basically to show them the options for reducing the screen time. This was a 1-minute video which we circulated during lockdown. This has got just the general guidelines of the fact that they should not be keeping the screen closer to their eyes when they are reading. They should maintain a distance of at least more than 20 to 25 centimeters, and they should be more outdoors. They should be parents should be helping them out. Parents should be the role models, and they should try to engage them in non-screen activities, thereby preventing the progression of myopia. So these are just small tips for parents which we created. And what are other drugs apart from atropine? Because atropine in itself is a pretty long webinar, and it can eat away all the time of our meeting. Other drugs which are coming up or which have been used. So this is an old article on pirenzepine where they found that it was effective. It has not come to market in India. And 7-methylxanthine, again, a couple of studies were done, showed initial promise in early part of second decade of this century, and they could show that oral tablets once or twice daily were effective in reducing the progression of axial progression. The study was published from Denmark. The first one was published in 2008, and there was a follow-up study in 2012 also. But then this particular drug again is not currently available in Indian scenario and not available in Indian market. So this was regarding the pharmacological interventions. What are other apart from this? There are a lot of
1 minute.
live research which is there. There's a lot of buzz in optometry also, and orthogonal lenses also are being promoted and being used for progression to control the progression of myopia. The main crux is that when you're using an orthogonal lens, it is not just the flattening of the cornea, which is normally helping in controlling, helping in myopic. What should I say? It is helping in reducing the myopia. Basically, it reduces the defocus which occurs in periphery. So the defocus and the same defocus that occurs in a normal glass has also been. There are new glasses where hyperopic defocus causes the progression, as you can see from this image, which is basically taken from the highly aspheric Lancet Target website. Basically, what the theory is that when you wear the glasses, normal glasses, they will focus on the retina in the center part of it, but the peripheral defocus.
Time is up, sir.
Yeah. So this is the last slide. Yeah. So this particular lens are being promoted for, but not available in India. And this is the final slide. Keep myopia away. Go outdoors and play. More times outdoor would help in preventing the progression of myopia. Thank you so much, Aditya. Thank you.
Thank you so much, sir, for that very informative talk. I'm sure we have a lot of questions, and there'll be a lot of questions for you after this, so please stay with us. Next, we have a talk on pediatric cataract surgery, pearls in pediatric cataract surgery by Dr. Love. Sir, are you there?
Yeah, I'm there, but I'm not able to share screen. It is coming as share whiteboard.
Sir, first open PowerPoint, then share, sir.
Okay. No, it's coming as whiteboard only.
So just below whiteboard.
Yeah, I got it.
Yeah.
Can you see my screen now?
Yes, sir. Yes, sir. We can see your screen.
So thank you so much. And the topic of my presentation is how are pediatric cataracts different? So for many of us think that when we are good in adult cataract and without any formal training of pediatric cataract surgery, we will be able to do well. And this is where we land in such troubles. And this was a case which was operated by a good adult cataract surgeon, but not trained in pediatric cataract surgery. And what the surgeon did was implanted the lens in the sulcus. Half of the iris was missing due to maneuvering in the surgery. The lens was a single piece lens and leading to a decompensated cornea. So nothing much can be done in these cases. Once the damage has been done, what we did was just to remove the IOL and left the eye to cool off, and then we can give a contact lens later on in future. So we have to be very mindful that these children will remain with this kind of condition for next 70 years, at least 70 to 80 years. So the neatness of the surgery is very important. So just to give this message, I was given this slide. And when it comes to IOL power, again, it is not a miniaturized adult eye. Pediatric eyes are a shorter axial length, steeper cornea, smaller AC depth, and error in axial length measurements affects IOL power calculation. It increases by 3.75 diopters per millimeter in children as compared to adults, and a scan with maximum anterior chamber depth should be taken. That may be the most reliable one. Requirements for biometry, we have to have a handheld K and a scan machine. And this is how we do biometry on table. As you can see here, the child is already intubated, and we keep the full range of IOL in handy with us. The keratometry is done. We don't use eye speculum because that may cause error in the readings. And once it is done, ideally speaking, in the same sitting, it should not be done, but to avoid multiple general anesthesia, this is how we do it in our setup. Now, target refraction in adults, if we are able to give them 0 power for distance, it's a wow effect. But in children, we don't aim for 0 power. We aim for hyperopia depending on the age of the child, the status of the fellow eye, compliance issues, because too much of high plus power if we give and the child is not compliant with spectacles, then that may induce amblyopia. And again, depending on whether it is a unilateral or bilateral case, and what is the status of the fellow eye. Timing of surgery, adults, if till it is hypermature or mature cataract, it is an elective, or when it is an advanced stage of cataract. But in children, it is always an emergency. And in bilateral cases, it can be operated around 8 weeks of age, but slightly earlier in unilateral cases. And the second eye has to be operated within a short duration of the first eye, which is not in the case of adult eyes. In unilateral cataracts, myopic shift is more in the affected eye. So other eye refractive status has to be seen. And in visually non-significant opacities like blue dot and posterior polar cataract can be kept under close follow-up. Now, aphakia or pseudophakia, this is another category where we are different. Pediatric cataract surgery is different from adult cataracts. In adult, we always aim for pseudophakia. But in children, if they are of very small age, maybe less than 1 year, and with a shorter axial length and corneal diameter, then we leave those children as aphakic. So in those cases, we do a lensectomy, leaving behind anterior capsular rim for future IOL implantation, if possible. And in unilateral cases, it is always better that after surgery, we train the parents how to implant contact lens in the child, so that we can see that the amblyopia is not there. What IOL to implant? In adults, the full range of IOL is there, but in pediatric cases, hydrophilic is a strict no-no. And most of the almost all the cases, what we operate is hydrophobic lens, unless it is a scleral fixated IOL in older children, in which we use PMMA. Aspheric or blue blockers, again, its advantage in children is controversial, whether with the contraction of the bag, if there is slight decentration, the advantage of asphericity may be lost. Toric in older children, definitely, but not multifocal. I don't have any experience with multifocal lenses. Single piece and 3 piece, again, depends on the choice of the child, of the surgeon, sorry. Capsulorhexis, both anterior and posterior capsulorhexis is another difficult and different from adult cataract surgery, because anterior capsule is a very elastic capsule. Forceps, we use either a Utrata or microrhexis forceps. And nowadays for posterior capsulorhexis, we use vitrector, and even if the anterior capsule is fibrosed. And anterior vitrectomy is an extra step that we do. And this is one of the publications what we had, in which we compared vitrector rhexis with posterior capsule, manual posterior capsulorhexis. Suturing, adults we never do, but in children up to 7 years, we should always suture the main port, so that because the scleral rigidity is low and anterior chamber collapse may happen. So it's always a good idea to suture the main port. And beyond that age, it can be case-to-case basis. But in infants, the leakage from the side ports is also so problematic that sometimes we need to suture the side ports as well. And the most important thing is amblyopia treatment. And in adult cataracts, good surgery is the end of your contact with that patient. If you are given a good bilateral vision, then annual follow-up is enough. But in pediatric cataract surgery, it is the beginning. Very frequent follow-up is required for amblyopia management to keep assessing the visual axis opacifications, because the capsules are very fibrosis can occur, or cells can migrate to the center and cause visual axis opacification and IOP monitoring. So initially every 2 months, 3 months, and once the amblyopia therapy is over.
1 minute remaining, sir.
Yeah. I think it's over now. Thank you so much.
Thank you so much, sir, for that very informative talk on such a big topic in precisely 7 minutes. Our next talk is by Dr. Jaspreet Sutija on IOL implantation for infants. Where are we in 2021? Sir, over to you.
Thank you so much for this opportunity here, and it's a nice pediatric ophthalmology session. And moving forward where Lover just left us. So basically, I'll be discussing something about cataract surgery in infants. Now, in the older age group, when a child is maybe 5 or 6 years of age, probably things are much easier. But many of these congenital cataracts who present in infancy, we are in a dilemma now. What should we do? I mean, how we should go about it, the examination techniques, and what is so different. So I would be discussing in the context of Western literature versus the Indian literature, because the management is quite different as compared to when you compare these two areas. So as we know, as has been discussed in the previous presentation also, that it's not just the, you can say, smaller version of the adult eyes. These are different eyes. Children, I mean, the tissues are different. You have surgical difficulties when you're dealing with infants in these small eyes. That is the most, that is the time period when there is rapid development of the eye. I mean, there is an increase in axial length and the anterior segment structures are developing. So it becomes more of a difficulty and a concern how to go about in a child who presents with a cataract. The other problem is that whether we need to implant, whether we should implant the IOL in this growing eye, in a small eye, that's also something which need to ponder about, and the refractive challenges which come up. It's a you can say, because of the increase in the axial length and the myopic shifts, there is much more when you operate on these infants. So what is the debatable issues in the literature? Should we implant the IOL in these eyes or leave them aphakic versus a contact lens? So if we consider some of the advantages, I mean, some of the issues with the IOL implantation, the advantages provides a constant optical correction. You just put it the IOL and of course you have a good correction. You are placing the IOL within the capsular bag, it's a primary surgery, and you are avoiding a contact lens with its associated cost and effect. Now, what happens with the contact lens? The advantage is that you can change the contact lens power. So as the refractive power is changing, you can change the contact lens power. The studies have shown there is no increased risk of complications and additional surgeries which could be required with IOL implantation, and there is no spectacle dependency. So some of the studies in the West have shown that the infant aphakia treatment study, which was I think one of the largest studies, prospective studies, which showed that contact lenses were better than primary IOL implantation. Intraoperative complications were more in the IOL groups, and additional surgery rate was higher in this group. And there was no IOL impact on 10-year risk of glaucoma or the visual acuity. So IOL did not offer an advantage in these children. So where does this you can say where is the balance now? So there's a high incidence of adverse events and rates of resurgences in infants operated for congenital cataract with IOL as opposed to those who are left aphakic, as was shown in the infant aphakia treatment study. However, there are very few reports which say that a primary IOL implantation, primary IOL implantation is safe, effective, and advantageous. So these studies are much less as compared to the ones which have left the eye aphakic. So where do we stand? Initially, if you see the earlier literature, there were hardly any talk of intraocular lens implantation in infants. So when we did a PubMed search, we can see how the literature has increased when you just put in the search criteria. So there is a trend towards more trend towards you can say IOL implantation in children now. But it's if you have a child under 6 months, it's still a topic of debate. Many would leave the child aphakic because of many issues, because of the risk of post-op complications, or you have a high risk of glaucoma. But newer advances have helped us in overcoming these. So the Indian scenario is like most of the children are in rural areas, come from rural areas. I mean, problems of follow-up, you have hygienic conditions, contact lens would be an issue here. Education and understanding the disease, they might not understand how a contact lens to be put, what they require, the cost of contact lens, getting lost, and the socioeconomic status. So a lot of issues in the Indian context as compared to the Western. So we did this prospective study in infants where we implanted an IOL and studied them prospectively over a period of 3 years. And we had 20 unilateral and 40 bilateral cataracts. And of course, we were able to implant most of them in the bag. We achieved satisfactory surgical outcome with minimal vision threatening complications. And our visual axis opacification was not affected by the age at surgery. That's what we saw. So if we compare it to the Western population, we had a visual axis opacification in 17%, which is quite less as compared to the IITS group. The pupillary membranes were much less. We had no patient with glaucoma, and the additional surgical procedures required were in 22% as compared to 63% in the infant aphakia treatment study group. So basically, we also did a study to see the myopic shift in these children, and you can luckily and fortunately, or you can say there's not much of a myopic shift. Fairly, you can say in the range of 3 to 4 diopters when you study children over a period of 8 years. But there's a lot of age variability, and many studies are retrospective. Similar were ours also. It was a retrospective study. The rate of visual axis opacification reported in non-Western literature are much less than that of IITS. So other studies out of US report much less incidence of visual axis opacification. But yes, in the developing world, even though IITS has published that do not implant an IOL, considering our socioeconomic status from where these children come, and other factors, probably IOL implantations, many are inclined towards IOL implantation. So what are the other factors in the developing world? It's not the merits, basically, it's the demerits of the alternative options which are there in the developing world. Poor uneducated strata, no insurance, cost of contact lenses, as I have discussed. I mean, uncorrected aphakia because of poor visual outcome, putting an IOL gives at least a partial rehabilitation in such cases. And of course, it could be a good practical option in the developing world for these children. So can the site of IOL implantation make an impact? Now we know that the routine has been to implant the IOL in the bag, do an anterior vitrectomy and implant in the bag. But then there's a high risk of glaucoma in infants as well. And of course, the bag is small. That is again an issue. And probably the IOLs, what we are putting are the adult side. So probably it's not the bag where the IOL is meant for. Probably try another space. And that is the Burgess space. That's behind the posterior capsule. So we did a study here where we compared the intraocular lens implantation in the bag versus behind the bag, and we did not perform an anterior vitrectomy and found fairly good results when we did not do an anterior vitrectomy. And these results, we had followed these children over a period of 2 years. So they performed fairly well, and of course had less inflammatory sequelae.
1 minute remaining, sir.
Okay, so they had less inflammatory sequelae as compared to those in the bag. However, the visual axis opacification rate was same in both the eyes. And this is just to show you that table what we had. We did do adequate cortical cleanup. We did give a good steroid cover. That is one of the most important consideration when you're dealing in the post-op period with these children. So I'd just like to summarize here that modern surgical techniques and IOL material and experienced hand make it feasible to implant an IOL in an infant eye. Yes, below 6 months is still debatable. You have to be very selective in your cases. Primary IOL implantation seems to be a viable option in our country. It can be applied to infants with adequate consideration. That's what I said. You have to be very specific where you implant an IOL. Every case you cannot be implanting an IOL. And that is what I'd like to say, that yes, when you have to plan an IOL in infants, you have to be very selective. You have to do a proper examination, study their parameters, and then only go about it. Thank you for your attention.
Thank you so much, sir, for that talk. We have finished well beyond time, so we have 30 minutes to have our questions. I would request the panel to take up questions and take up with the speakers.
Can I request all the speakers to please switch on the camera? Yes. As of now, we do not have any questions in the Q&A. Maybe they have questions to each other. That would also be wonderful.
So I have a question with with various companies now coming up with higher concentration of atropine for myopia. I think this is for Dr. Jethani if he's there. So we've seen a lot of resistance even with 0.01%, and I think that's not adequate enough. So 0.07 is come, 0.01 is now getting a little more obsolete. So are more companies coming in? Any experience anybody's used till now?
Which company? Because only 0.05% I think Entode has come up with, no?
Yes, I
Yeah.
saw
I mean,
0.07.
I've only seen that. I don't know if any other companies have come up.
Entode is, I think, come up with 0.07 also, and one more company.
Okay, because I've just seen 0.05%. So it has come up, and we have started using in patients who, in spite of progression with 0.01, like, because earlier on we were doing even the PD, the morning and evening, and in few patients with when I started in the morning, they are complaining. They are complaining of problems. I don't know if you have faced the same thing.
Yes, ma'am.
The children are complaining even with the 0.01% that they are seeing blurred little bit. Yeah, and so I think it was like, so I have stopped in, I think, at least 3 patients the morning dose of atropine. So maybe a 0.05% in only a few cases where it has not been, like we have given a 0.01% and it has not worked.
Do you
I
think
have
it can
not seen the
replace,
0.07%. I don't know if Dr. Jitendra is there or not. Anybody else has seen 0.07%?
Not
Shruti or Dr. Jasprit?
I haven't seen. No, I just 0.05%. That's what I'm aware of. Not 0.07%. No.
Even 0.05% I haven't started giving out personally yet, ma'am. As of now, I just do the BD dosage of 0.01. Like you said, I do see patients complaining of a little bit of blurring, but not that much. But
Yeah.
with 0.01, all my patients with 0.01 were absolutely problem free, but with 0.05 there is an issue. 0.05.
Yes. But
Twice a day, there is a small, of course, it's not, I mean, very few patients, like if you take the number, if you give, there is very, I think I just have seen 2 patients. I don't know if it is, well, in those patients, we have started BD, and twice a day. So I
actually, ma'am, we did measure their pupil size and there was a difference between.
Yes, yeah, definitely, yeah. In myopia, have anybody like the new seed contact lenses? Have you all tried? Because
no.
The orthokeratology, ma'am. Yeah, the
orthokeratology. Yeah.
So Seed has, in fact, the soft contact lenses for myopia control are also, they're not commercially available. We did some research studies on it. We had to stop in between because of the COVID. But orthokeratology since 2017, quite a favorable result. Combination of ortho-K and atropine is further the best.
Okay. The only limitation with orthokeratology is that you cannot order it more than -5.
They have,
you have up to -6.
We have designs which have gone up to even 8, -8 and high sale. But yes, I mean, I would personally not like to because the zone is very small in that.
Small, yeah.
So because up to 6 is fine. Up to -6 and -1.5 sale is very good results.
Yeah, the parents who are billing are mostly all those children who have more than these numbers. That's the problem.
Yes. So the soft contact lens for myopia control is very soon going to be commercially available. And that should be an alternative in case we can't do ortho-K for them.
Yeah, I think the seed contact lenses, even we have contacted them but I think the cost is much more now. It's around, the cost it's very expensive.
Cooper Vision is going to come up. Cooper Vision is going to come up with the soft ones, better priced, ma'am.
Okay, these are the multifocal ones with the hyperopic defocus lenses.
Yes.
Okay.
Yes.
Okay. So the glosses are not going to come yet, I think. No.
Yes, that too. Post Diwali, they are Essilor and Hoya both are anticipated to bring it commercially in the country.
Oh, that's good.
Process. Glasses will also come very soon.
Yeah, I think the glasses are doing, I mean, would be probably much easier as compared to the
Much
contact
easier.
lenses.
Yes,
Start
yes,
with
yeah.
at least the concept we
Yeah.
can bring it to the
Yes.
parents.
Yeah.
Orthokeratology is very good, but has a very limited kind of selection criteria is also very strong. But the glasses are coming, the soft lenses are coming. So I think by next year we should have a range of products for myopia control.
Yeah, that'll be really good if the Hoya lenses they are coming very soon. And Shruti, you have also seen a large amount of patients of ACEs, acute comitant esotropias, you know. So I think all of us are seeing a large amount of these cases. Is it really due to the digital strain, or have you found something else?
So we do the entire gamut of testing, ma'am. We do eliminate everything else. I, in fact, do an MRI as well in children because we don't want to take a chance. And in spite of everything, even their BV parameters, it just seems like it's come out of nowhere. And then there's always this history of long, prolonged digital use, and that kind of sticks out as the only positive factor. And one of my patients did improve on their own in, over the period of 6 months, and I think it took about a month or two. And then, but it was usually they're large angles. That's what I have seen. They're not these small angle squints. They're usually large angles.
Exactly, yeah.
And then one adult required surgery for really, and this guy had been this lady had been having it for over a year. So so when there was no other option, and actually they do really well post surgery. And
Yeah, actually, I think they had the best binocularity post surgery because they always had a good. They're dot orthos, you know.
bring them within the alignment range of like within 8, and then they really
Yeah, it's really because I think because the binocularity has been previously also very good. Now, reason why they do much better than other children.
The alarming that you see it in younger kids as well
I think-
now. The younger ones I have started seeing. I saw one and I was quite surprised. I want to know if there are any experience with you, ma'am, or anyone else on the panel seeing younger kids with AACs.
Yeah, there is sudden actually spurt of ACS, acute comitant esotropias. I'm also seeing quite frequently nowadays. We used to see probably once a while, but yes, it has become common. Younger children have also, come.
We are seeing more in is the 18 to 20-year age groups. I mean, that's what I mean.
It's again the accommodation AC by A ratio disruption because of excessive near work, and that lead is happening. So one correlation can be that too also.
They're giving a proper history, yes, because I mean, we're seeing so much of screen, probably 5, 6 hours, 7 hours of mobile phone, what they're saying. That's basically, there's a very, you can say, specific history what they're giving. And probably I think trying Botox in these issues were not non-resolving or something could be a reasonable option if they are, obviously they are binocular. So if them just give them a little bit of binocularity, they might maintain that.
So one question on the newer EDOF lenses for kids, older kids. Do you think it's an option? Do you think these different EDOF lenses which are coming in, are they good options for kids? And at least
I have not found them that useful in children. I have implanted a few initially when they came, but not really that you can say convinced by what they preach. I'm quite happy with the other lenses, the 3-piece or maybe the single piece which are going on. I didn't find any comparative advantage of these EDOF lenses in children as compared to the routine lenses which are available, the hydrophobic acrylics. I think
we lost some of our panelists.
I think these Eyhance lenses are magnificent from myopia are good options when it comes to using it for pediatric IOL implantation. Especially when we are doing unilateral cataracts, I think they are quite good because we don't need that much amount of near addition. I've done quite a few, and I think they are a good option.
So you can try which one is good. I mean, you have different views. So no doubt, I mean, it's try it and see whichever works best. Yeah.
I don't think that. I've used iHands. They seems to. I mean, both Magnificent and iHands, they do have at least some intermediate vision is definitely there compared to a monofocal.
These are for the early teens, that's all. Young adults, or
What?
even what age group do you generally plan them for?
So all these things we can do only after 6 to 7 years of
6 to
age.
7.
Normally, I have not implanted in very young children, but above 6 to 7 years, because only then they would actually tell whether they are having an intermediate vision.
Benefits.
I mean, the control is when they are when they can appreciate that subjective benefit.
Any other questions?
What Dr. Actually, my connection got disconnected. Dr. Jitendra was saying about the multifocals.
We were
No, madam,
discussing about
not
EDOF
multifocal, madam.
lenses.
Only iHands and Magnificent lens. I have never used multifocal. I have never tried also.
Okay. No, I heard iHands is a very good lens. I have put it in a few, and it is, but not in a bit. How old even you're doing after 7 years of age?
After 7 years of age, yes. And especially I started doing in unilateral traumatic cataracts.
Traumatic cataracts, okay.
That was the starting point. I just wanted to see how good they would be binocularly, and above 7 years mainly because they won't respond. Earlier than that, if I implant in maybe an infant or 3-year-old, I may not be able to guess whether they have good intermediate vision or not.
Okay.
No way to find that out.
Dr. Swati had spoken about dichoptic therapy. I would like to know, like, do you use Binox, or what's the app that you use, and how does
We
it
do
work?
it on app actually. We were just given a game by some other company. So it was a Tetris game. So that's what we did it on.
Okay.
That is free. Shruti. There are free dichoptic games on Play Store. Tetris is free. I mean, you can download. There are Snake, Tetris, and Robo. There are 5-6 games which are. Which you tell the parents to take a red blue glass and download those apps.
Yeah.
There are paid versions also. Same games you have paid versions.
Yeah, I use this Lazy Eye Arcade. I use, but not.
Lazy Eye games. Yeah, you can put those keywords. Lazy Eye video games.
Yeah, I did use them, but then I think that website is no longer active. So now I have to search. Binox did come up with home vision therapy.
There are three, four companies, or if you
more than that.
CureC is also there.
Yeah, CureC is also there.
CureC is even having the similar those Gabber patches also. They are having those Gabber patches stimulation of what is that perceptual
learning. Perceptual learning.
Yeah, perceptual learning.
Yeah, I agree.
But it is way cheaper compared to Revital Vision, whereas Revital Vision would be around 35,000.
Yeah.
CureC is much cheaper. I think it is around 10 to 12,000. So that way it becomes easier to convince the patient.
Yes.
What is your criteria for dichoptic therapy? Like, what are the patients you're actually including in the dichoptic therapy? You have improved them with patching, and then after that you're doing you're giving it simultaneously with patching therapy.
No, ma'am. In this particular study, we actually took.
I was okay. Sorry, I thought that should be okay. Yeah. So.
Yeah, so we just took anisometropic patients of mild to moderate grade of amblyopia, and one group received the patching, the other group received only the dichoptic therapy, no patching. So as a primary therapy, we gave it, but yes, of course, in a certain subset, in a very particular subset, you can't easily give it for all patients, but mild to moderate kind of only anisometropic amblyopia is what we used it till now. But we would be using it, we are trying to use it, in other kind of amblyopia also, if it makes difference in those amblyopia also, because studies say even the strabismic amblyopia may be improved with that after the alignment.
The problem is they get bored of these things, so whatever they study. So the compliance issues would come up in these things.
Unless the technology improves to bring about more games, actually.
Yes.
That's the concept. We did a study, ma'am. We compared the monocular version of the game versus the dichoptic version of the same game. So we had the dichoptic game, and then we removed the blue blocking glasses and got the contrast at 100%, and we compared two groups. And it was a small, just like an in-house study, 15 in each group we did. And we found that actually dichoptic works pretty well compared to the monocular version of the same game over a office period. Like we gave them 10 hours of therapy.
These are children who had improved to 6/10 after your patching therapy, and you had a stereo of 100, and then you tried, or you they
I've never been put on patching before.
Okay.
Patients who have undergone refractive adaptation,
Mhm.
they have undergone their refractive adaptation. They have not had any patching done before. As a primary therapy, we instituted this, and it gave a good result actually, ma'am. It was good.
So what is the comparison between, you can say, younger children versus older children, say 14, 15 years age group versus a 5-year? Obviously a 5-year would improve, but what about us?
Yeah. So my study actually dealt with slightly older adults, older children. And I don't remember the results, but all I can say, the age group was a little large. So it really not much to comment unless we have a real subset of children in a specific age group. But I do believe dichoptic works better in adults better than patching therapy as an isolated therapy. So, but
I think it's mainly because of compliance, because older children are not so compliant with patching as compared to younger children. So that's what we found out in our own study also, that younger children were quite compliant with patching as compared to children who were more than 10-year-old or so. So they were more fond of playing video games.
I think the younger children also, the biggest problem is compliance, like ma'am said.
Yeah.
Because they also have to learn how to use the keyboard, they have to learn how to use the
Yeah,
mouse.
that is true.
Most of them don't do that. They're very happy with an iPad, and these are not available on iPads.
That is true.
So that becomes a bigger problem also.
At least it's very variable. Some improve, some don't improve. So really, we have to know what are the cases. I don't know. They've not been able to really come up with the conclusion which children improve, which we give them all, but we don't have.
But I think
I think an isometropic amblyopia improves. Yeah.
To give them a good time for refractive adaptation, I think that works. So before you
2 months.
Refractive adaptation is more important.
Yes.
So in these anisometropics, like what's it like, what type of refractive errors are you seeing? Like
that is true.
Astigmatism would be difficult to treat as compared to the others.
Absolutely.
So in anisometropic amblyopia, very high power. Anybody using LASIK? I'm doing all the controversial.
Not yet there.
Why not? Why not? Like, I'm just giving. Like Jitendra, you must have tried.
Under GA.
Jitendra's got. No, if the suppose is cooperative, a 10-year-old, and you have a -10 or a 12 in one eye, anisometropia.
I would go for patching only, madam. I am more into patching.
No LASIK?
LASIK? No.
I'm reading in it. I'm trying another controversial.
No LASIK at all. No way.
So if these contact lenses are now freely available, then what would be your first choice? Atropine or contact lenses? Atropine has an issue with compliance again. The parents are not so much convinced, maybe, or some of them don't.
If atropine has an issue with compliance, my contact lens will not have an issue with compliance. Compliance is basically related with the mind. It has nothing to do with the therapy. Atropine is much easier. There is hardly any side effect. I've been putting atropine in my kids since 3 years. So I don't think atropine has compliance is always an issue with therapies. Contact lens also, they will, there are problems with all kind of therapies when they become chronic.
Yeah. But I personally feel the glasses would be a game changer if they work, because then there is actually no extra intervention. That would be a primary intervention. And
the problem I see here is my point with glasses is that this is the 5th generation glass, and earlier 4th generation also came up with a stronger bang that they are working. And this is the 5th time they are saying that this is working. And so the trade aspect of it is very difficult to, that is a very strong confounding variable. And that is the reason why most of the ophthalmologists have their own doubts that the glass would work.
Unless RCTs are there to
Yes, very
For
true.
that,
Very.
I don't think there's going to be a lot of takers unless there's enough RCTs. Yes, sir.
It is coming out very expensive for the Indian patient, and the claims are just 30 to 40% reduction in the myopia progression maximum.
Yeah.
So that's also could be industry related studies and things like that.
But in SEED, they were saying they did a RCT with LVP, and I remember they're doing an RCT with LVP, and so maybe we could rely on that result. I don't know.
The contact lenses are so far, yes,
Yeah.
claiming 50 to 60% progression.
There's a clinical trial going on.
Madam, similar claims were made by previous generation. This is Holt lens, which is the 5th generation. Previously, there was Salt lens, and before that also there were lenses where Hoya and Essilor claimed that this is the final answer to progression or controlling the progression of myopia.
And the cost itself is coming out to be too high,
yeah.
that 10,000, 8,000 rupee a pair of spectacles for a
pair.
child will not be easy for every parent to even opt, and then progression, change in prescriptions and all those.
And to be honest, I imported a pair for my own son because I am also very desperate for that his progression should be halted. So I got a pair, and to the doctor it costs around 8,500.
I meant that.
I mean, it's quite expensive. Cost to fir bhi, I mean, I would say that cost is just one of the issues. If it is working, means there will be more. There are a lot of people who would be happy to give the money. But there are a lot of studies which are not really strong studies. Like if you see ATOM study, there are 400 Singapore children RCT placebo controlled, comparing one eye with other eye. Can we have such an RCT for these glasses? We can't have. I mean, one eye has a Holt lens and other eye has a normal lens. Who is going to do that? I mean, it's like the power of study is also very, very important.
Yes. I think we'll have to, I think the time's up. Sorry. We'll have to close the session.
I think one of us can do thumbs up.
Okay.
Thank you, Suma. Thank you very much, and thank you.
Rohit was here.
I was not a part of the session. I was only here as an audience. I was not supposed to be seen or heard. I was only supposed to see and observe.
Okay.
Okay, thank you.
Good. Thank you very much. Of course, I didn't attend whole, but I found the discussions and all also, and some presentations very, very interesting. And thank you. It just shows that there is so much still left to be done as we are evolving in our management for these kids, especially their vision related and their binocular vision disorders. So the future is ours as we move from best corrected uniocular visual acuity to best binocular visual acuity. I think the world is still waiting for us to come out with answers for a lot of problems. Thank you, everyone. Thank you very much for a very lively and interesting session.
Thank you.
Thank you.
Thank you.
Thank you.
And the chairpersons, the speakers for finishing it bang on time. We have the chairperson for our next session, Dr. Rohit, with us. And I think Dr. Rohit Saxena would be very happy to see that he's getting the hall around 6 minutes before time. Am I right, sir?
Yes, I believe so.
The only question that I have is, sir, with respect to the speakers, we are not able to find the first one, that is Dr. Rashmi Bansal. We have Dr. Jyoti with us.
Yes. So we'll start with Jyoti. There is no problem.
Would you like to still wait a couple of minutes, sir?
Yeah, we will. I think we'll wait for a bit. We can just do general chit chat in the meantime.
Sure, sir. How's the
and we can have the speakers as they join in. Dr. Manjula is here, Dr. Jyoti is here, Dr. Paramita, Dr. Reena, Dr. Ankur. So we have a lot of speakers who are Dr. Sandra. So we have a lot of speakers who have connected already. So that's very good.
So also the total time allotted to each and every speaker, like in the previous session, was 8 minutes. What we did was we gave them a timer of 8 minutes. At 7 minutes, I used to just unmute myself, not switch on the camera, but just give them a timer that says 1 minute remaining. And at 8 minutes, we were instructed by the organizing committee to stop the screen sharing. But in case if it's on the concluding slide, we give it a couple of seconds more.
Sure. So wherever it is, sometimes we don't know, some people don't have a concluding slide. So when the timer is up, just wait for maximum 15 seconds or so, 15-20 seconds, and then we will stop the
Sure,
process.
sure. And we are also taking the discussions right at the end of the session, sir.
Yes, so I think yeah, we could do that. That's
Correct.
fair enough.
And
Sure.
one last thing, we have Atul from the Grover AV team. He is also present with us. He's not switched on his camera, but he's there. So in case if you need any technical assistance for anybody, he's definitely capable to help you out, or anybody
Great.
else. Sometimes it happens that they're not able to share the screen and so on.
Right.
In the meanwhile, I was just checking. Dr. Renu has also not joined in. So because you are the chairperson, we've got the co-chairperson, Dr. Renu Grover. We've got the convener, Dr. Ankur Sinha. We've got co-convener, Dr. Digvijay Singh. And we've got the moderator, Dr. Paromita Datta.
Right.
So since you are the only one who's present over here, I believe you would be the referee and the umpire and the MOC as well.
Dr. Paromita is, I think, there in the group.
Yeah. Good evening, everyone.
Ankur is here, Paromita is here.
Yeah.
And I'm sure Digvijay should join if he is aware of it. Sometimes there has been an issue with the information reaching the speakers and the members. So
Correct.
it doesn't matter. We'll just see. I'm sure we'll manage.
So just to give a heads up, we are getting started in exactly 2 minutes from now. That
Great.
will still be 2 minutes before time to ensure that we introduce well, and I will introduce all of you, the chairperson, co-chairperson, conveners, and the moderator, and then take it forward from there. Hello, Dr. Paromita, can you hear us? I believe Dr. Paromita's internet connection is a little...
Paromita is connected but not speaking and possibly not listening, but I'm sure she will also join us.
I think it is...
Yes.
Hello, Dr. Paromita. Absolutely.
Hello, Paromita is not listening.
नहीं हो सकता है screen hang. Yeah, right.
It's difficult to make out who waving to, sir.
We were calling out your name, Paramita. Hello, and
I couldn't hear that. I could not hear that.
So we have Dr. Manjula, Dr. Sandra, Dr. Siddharth, Dr. Jyoti, Reena, Dr. Jithani is also here. So we have quite a few people.
Hello, sir, and thank
Hi,
you so
hello.
much for the invitation, Dr. Rohit, Dr. Ankur, and everyone else.
Just to give an update, we will get started with Dr. Jyoti first.
yes, no, the
First
first
one,
speaker
Dr.
is Siddharth. Siddharth has
Siddharth,
joined.
no? Yeah, he's
Siddharth
there.
has joined.
Yeah.
Oh, okay. So maybe I don't have the updated schedule. According
Yes.
to my schedule, it is Dr. Rashina Bansal going first.
No, Dr. Rashina is not here in our group.
No,
It
Rashina
seems.
is not.
She's not.
But Siddharth is the first speaker. He's there. Jyoti is the star speaker. She's here.
She's also there.
Then I go. Reena is there.
There,
Yes,
she's
Reena is
there.
there. She's not turned
Yes.
on her screen.
Dr.
but
Manjula is
she's
also there.
Dr. Manjula is there. Dr. Sandra is there. Savleen also, I'm sure she'll connect in a bit.
Yeah, she's there. She's
Yeah,
there.
she's there. She's there. Actually, she's using an different
Maisha's
name.
name. Yeah.
Yes. She doesn't want us to know, but her photo is telling us. So you can tell us the moment we are supposed to go live. I believe that people can hear us because there is a message on the chat saying that nothing on screen. So maybe they are hearing our chit chat, which is not such a great idea, but
Yeah.
and Nikhil, your audio is very low. You're the only one I couldn't hear. Initially, I thought it's a problem with my speakers, but
Is it better now?
yeah,
Oh,
yes,
yeah.
yes.
Sorry,
So
it
it
was
got
set
louder.
on auto, so I just changed the settings to manual. Is this okay?
Yeah. So when we go live, please do tell me.
Atul, can we go live in the next 30 seconds?
Yes, sir. Live.
Atul, yes?
Yes, sir. Yes.
Yes, okay. To get started with our next session at 5:30, we have our chairperson with us. We've got Dr. Rohit Saxena. We've got our co-chairperson, Dr. Renu Grover. We've got our convener, Dr. Ankur Sinha. Our co-convener, Dr. Digvijay Sinha. And our moderator is Dr. Paromita Datta. I request the chairperson to please invite our first speaker, Dr. Siddharth, on the camera. And I also request Dr. Siddharth to please start the screen sharing.
Thank you. So this is the part of the strabismus. We just concluded the pediatric ophthalmology part of the pediatric ophthalmology and strabismus subspecialty day. And this is the basic strabismus. And subsequently, there'll be the advanced strabismus. So we start quickly. We can do the discussions in the end. Dr. Siddharth Agarwal from King George Medical University will be speaking on basic steps of strabismus examination. Dr. Siddharth, please.
Good evening, Dr. Rohit. Thank you for the invitation and greetings from Lucknow. So I would be speaking on the basic steps of strabismus examination, and the questions to be answered at the end of examination are whether the patient we are dealing with is actually having strabismus, what type of strabismus we are dealing with, what would be the refraction, visual acuity and binocularity of this patient, and whether that patient can be managed by me or whether I should refer the patient. As you can see, not many instruments are required for the basic examination of strabismus. And that is probably one of the advantages of our subspecialty. We don't require expensive equipment, unlike many other specialties. The examination can be divided into vision and refraction, motor examination and sensory examination. Initially, probably in the first visit, you would like to do the motor examination first, but in subsequent visits, it is recommended to proceed with the sensory examination prior to the motor examination. All attempts must be made to have an idea of the visual acuity of the child by using an age-appropriate method. Modalities like the optokinetic drum or preferential looking should be used in small children, and e-chart should be used with proper explanation in preschool children. Refraction should be performed under adequate cycloplegia depending on the age of the child and the race of the child. A Bruckner test is very useful, specifically when the reflexes are asymmetrical or the pupillary reflex is unhealthy. An attempt must be made to assess the deviation under cycloplegia, as it gives a very accurate estimate of the accommodative element of the strabismus. And if amblyopia is suspected, one must perform an amblyopia workup, and the retina examination and fixation should be checked when the patient is dilated. Coming to the motor examination, anomalous head posture should be noted. The compensatory head posture has three components: face turn, rotation of the head, and elevation depression of the chin. The Hirschberg's test, which is the backbone of strabismus, should be properly noted and documented. And the cover test and the cover-uncover test, which I will demonstrate in the next video, should be carefully done. The patient should be made to fix on an accommodative target, as is seen here in the spectacles of the examiner, and this is done when performing cover test for near. The prism cover test would also be demonstrated in the next video, and the subjective tests are indicated in patients with concomitant deviations complaining of diplopia, and they give a good quantitative estimate of the deviation and are useful in follow-ups. Motility limitations, the versions, when we are checking both the eyes together, and it is useful to document the limitation in version by photographs. If the versions are limited, they should be confirmed by performing the duction movements. And finally, the vergences. Now, this is a short video to demonstrate the cover test and the cover-uncover test for beginners. I'll be playing this video repeatedly. It's a short 3-second video, and the right eye is observed as the left eye is covered. So this is the cover test. And as we uncover the left eye, we see the slight movement in the left eye, which comes back to take fixation. This is the uncover test. So when you are covering the fixing eye, observing the uncovered eye, that is the cover test. And as you remove the cover, and observe the eye under cover, that is the uncover test. It gives you a lot of information, whether the eye is squinting, how much is the deviation, whether the eye is squinting in or out, how readily the eye is coming into pain fixation, and so on. Now, once we have an idea of the deviation, we perform an alternate cover test and we try to neutralize the deviation by using prisms. It should be noted that the prisms are placed over the non-fixing eye and increased till no deviation is observed. Once the prisms are placed over the non-fixing eye, the fixing eye is covered and forced to take deviation. And we go on increasing the prisms till no deviation is observed. It's giving us an idea of the amount of hard angle alternating esotropia. Loose prisms are being used to neutralize the deviation. Loose prisms are used when the deviation is larger than 40 prism diopters. Now coming to the sensory examination, in patients with diplopia, a diplopia charting is very useful. The Wirth 4-dot test gives us an idea of the binocularity and the stereopsis by using dots like the Randot stereogram help you to quantify the stereopsis. Now beginners should watch out for the oblique muscle dysfunction seen here. The right inferior oblique is overacting, the V pattern. Then incompetence, you can see in the up gaze, the left eye is not moving up. And motility limitations. This child of Duane syndrome has motility limitation of left abduction. And similarly, large angle deviations like this one, they are best referred to a specialist and the beginners should not try to handle them. One should be careful about the cyclical deviations which are present sometime and absent at the other times. Now the take-home message is you will need at least 2 to 3 visits to complete the examination. And if in doubt, re-examine the child, call him or her again. It is advisable to perform the sensory examination before the motor examination once you have an idea of the deviation. Cover test and the cover and
1 minute remaining
are the basic foundations. And the strabismus surgeon should be well versed with them and be watchful for gaze incompetence and mobility limitations. They should not be missed. Thank you very much.
Thank you, Dr. Siddharth, for such a nice talk on strabismus workup. And next we have the pattern strabismus, the patterns in strabismus. And I would request Dr. Jyoti Matalia from Narayan Netralaya at Bangalore to share her screen and deliver her talk to us.
Yes, can you see my slides?
Yeah, Dr. Jyoti. Thank you.
Thanks, Dr. Ankur, and thanks, Dr. Rohit, for this opportunity. I'm going to be speaking on pattern strabismus. So I'll take you through these various options of pattern. First, definition. It's a significant difference in the size of the horizontal deviation from position of up gaze to down gaze and can be termed as A or V pattern. And what we need to understand, it can be as high as 50% of the horizontal strabismus. Second is the nomenclature was initially called as Tent or Tapie syndrome by Jampolsky. But later on, now what we call as A and V pattern is introduced by Albert, but some people also call it as alphabet pattern. So what is A pattern? When the deviation, that is a diversion, increases more than 10 prism diopters from 25 degrees up gaze to down gaze, it is an A pattern. Whereas V pattern is when the conversions increases more than 15 prism diopters from the same gazes, right? Then coming to the classification, which is based on the deviation in primary gaze, it could be A pattern esotropia, A pattern exotropia, V pattern esotropia, V pattern exotropia, or a lambda, Y, X, or a T pattern. Now, what is V pattern esotropia? When the esotropia increases more in down gaze, What is A pattern esotropia? When it increases more in upgaze. And remember, when we are talking about the pattern, the first quint what we talk about is in the primary deviation. So the ET is what is measured in primary deviation, and then we look at the change in pattern. When we talk about V pattern exotropia, we are basically talking about the exotropia more in the upgaze, and A pattern exotropia when the A pattern or the exotropia is more in the downgaze. Then coming to the causes, it could be basically either a horizontal muscle overaction that was previously thought, or a vertical muscle. In certain Crouzon syndrome, it's anatomical factors, but what is commonest thought is the oblique school, which is introduced by the NAPS, which means in A pattern, there's a superior oblique overaction or an inferior oblique underaction. And in a V pattern, it's an inferior oblique overaction and a superior oblique underaction. So how do you examine these patients? Basically, we want the head tilted downwards while they're fixing to a particular position in 25 degrees upgaze and tilted backwards. That is, you put the chin up and down to see, or you show a target going up and down in these particular positions. And then you examine the versions in these defined position of gaze, followed by checking the torsion to look for oblique overaction either on the fundus or indirect ophthalmoscopy. Now, when you're looking at the versions, this is the place that is a dextro version that you look for a left inferior oblique overaction. And the dextro depression is for the left superior oblique overaction or underaction. In this position, we look for the right inferior oblique, and in this for the right superior oblique. So the underaction and overaction are picked up when the eye is adducted for the obliques. Now we all know for oblique overaction, inferior oblique is an elevator taking an angle of 45 degrees with the horizontal, and superior oblique is a depressor making an angle of 45 degrees with the horizontal axis. So when you have inferior oblique overaction, you will get a position of plus T, that is eye tends to move up, and similarly it moves down in a superior oblique overaction. Then how do you measure it on torsion? So normally, if you see the foveas at the lower 1/3 of the disc, but that is in the lower 1/3. But if you find that the fovea has gone below that, as seen here, then the patient has a bilateral excyclotorsion, which we look at on a fundus photograph. And if it is higher up, that is a fovea above the lower 1/3, it's a bilateral encyclotorsion. But when you're measuring the torsion on indirect, it's exactly different because you're looking through a 20D lens, and then in that case, the foveas are the upper 1/3, and if found below it, it is intorsion, and if found above it, it's extorsion, and this is irrespective of whichever eye you are seeing. So let's look at some examples. As I said, primary position esotropia, then we look in upgaze and downgaze. Nothing is there, no change, indicating no pattern. In this particular case, you see an esotropia, which is decreasing in downgaze and reducing in upgaze, indicating a V pattern esotropia. Then we look at the eyes in the side gazes and notice that the adducting eye is elevated. That means there's a bilateral inferior oblique overaction. In this another child, there's an exotropia in primary position, which is increasing in downgaze compared to upgaze. Therefore, A pattern exotropia. And if you look at the side gazes, that is the adducted eye, you will notice that the eye is depressed, indicating a superior oblique overaction. In this case, where there's an exotropia in primary position, it seems to increase in upgaze and also increase in downgaze, which is an X pattern exotropia, which means that there is not that inferior oblique and superior oblique both are overacting, which cannot happen. It's the tight lateral rectus which tends to slip, giving this impression of an X pattern. Now this, on the other hand, if you look in primary position, there's orthotropia, which continues to stay in upgaze, but downgaze, there's a larger exotropia. That is a lambda pattern, where it's a variant of A, common in primary and upgaze, but exotropia and downgaze. And if you look at the adducting eye, you will see that the superior obliques are overacting. Similarly, in this patient, you will notice that the eyes are orthotropic in the primary and downgaze, but in upgaze, you will see a large XT, which is a Y pattern exotropia, a variant of V, comitant in primary and downgaze, but XT in upgaze. And if you're seeing the adducted eye, the inferior obliques are overacting. So then let's come to the management. It's essential surgery. And indications would be if there's a presence of abnormal head posture to provide binocular vision and improve the fusion that way, and to restore the patient's normal facial configuration, that is cosmetic reasons. So how do you manage A pattern? You first look for superior oblique overaction. If absent, then we do a vertical displacement of the horizontal recti following this particular mnemonic of male. Medial rectus to the apex of the A and lateral rectus to, medial rectus to the apex and lateral rectus to the open end, where a half tendon width of vertical displacement corrects 10 to 15 PD of pattern, and a full tendon will correct 20 to 25 diopters of correction. If, however, the superior oblique overaction is present, then yes, you weaken it along with the surgery for the horizontal recti. And if you weaken it temporally, it corrects about 35 PD of the pattern. Posteriorly, if you correct, only corrects the pattern with sparing the torsion, but nasally will correct a large. So be careful that it may cause a superior oblique palsy subsequently. So let me show you the surgical steps. For tenotomy of the superior oblique, take a superotemporal fornix incision, hook the superior rectus muscle, look for the glistening white band of the superior oblique tendon beneath. Use a small muscle hook to pick up all the fibers of the superior oblique tendon. Place a small hook underneath the isolated tendon and cut the muscle along the insertion. For posterior 4/5 tenectomy, split the tendon carefully at the anterior 1/5 and posterior 4/5 junction. Perform tenectomy as shown here. Superior oblique split tendon elongation. Isolate the superior oblique tendon, measure the desired amount of lengthening, place a sixovical suture on half the tendon width at one end, split the tendon horizontally, cut it in a Z fashion. Tie these cut ends together to elongate the tendon. And this is how you will do for the superior oblique. Now, what happens when you have a V pattern? You look for inferior oblique overaction. If it is absent, you do the same thing, vertical displacement of the horizontal recti in the same fashion. And there, the same thing applies. Half tendon will cause 10 to 15 prism darters of pattern correction, and a full tendon displacement will result in 20 to 25 prism darters of correction. But if there's an inferior oblique which is overacting, then you have to operate on it. Either when you do a recession or myectomy, less than 30 PD of that gets corrected. But if you have more than 30 PD, you have to simultaneously do a tendon displacement as well. And if there's associated DVD, you do an inferior oblique anterior transposition. Can I show the video or do you want me to sum up?
I think you can continue, ma'am. I think 10-15 seconds now.
Yeah, just show a quick video.
Okay. Inferior oblique myectomy. Take an inferotemporal fornix incision. Hook both lateral and inferior recti as shown. Identify the triangle made by the vortex vein, sclera, and the muscle. Just lateral to the vortex vein, place the small hook. Place it flat against the sclera. Gently slide the hook beneath the inferior oblique muscle until the inferior oblique is engaged. Isolate the whole muscle by placing the muscle hooks on either sides. Look for any unhooked muscle fibers. For myectomy, place two hemostats 5 to 8 millimeters apart and excise the portion lying between. Cauterize each end. Allow the muscle to retract back into the tenon sheath. Anterior transposition. Clamp the end that is closer to its insertion. Then secure the inferior oblique muscle with sixovical sutures. The insertion should form a bunch. Cut it and reinsert the muscle to the sclera adjacent to the inferior rectus. The placement of the inferior oblique with regards to the inferior rectus muscle will depend upon its overaction and will follow the table as is shown. For those who are doing recession, we can do in the same way and put it at the Parkes point. So basically, to summarize, that when we have always look at the primary and reading positions, which are the important positions, check for patterns. Surgery for horizontal deviation should be done independently. Check the versions and confirm torsion. And if obliques are overacting, operate on them. If not, either supraplace or infraplace the horizontal muscles. Thank you very much.
Thank you, Dr. Jyoti, for such a nice talk on pattern strabismus. So we have had basic workup and understanding the patterns of strabismus. Now we move on to the planning of strabismus surgery. So we have Professor Rohit Saxena from RP Center AIIMS. He'll be talking to us about planning a strabismus surgery after the talks on workup and pattern strabismus. Yes, sir.
Okay, so you can see my screen?
Yes, sir.
Okay, thank you. So I'll just start at the beginning. So thank you very much, Doris, for the opportunity, and I'll be talking about surgical planning in strabismus. But there are some key things you need to see just before you start and pick up your knife. So some important points you need to be aware of. Some have been discussed earlier in the previous pediatric ophthalmology session, but it always helps to recap before you start surgery. So accommodative esotropias, we know that just the refraction can change the management. So they may just need glasses and not surgery. Always do age-appropriate cycloplegic refraction before you think of surgery. And just in case you thought only accommodative esotropias need refraction, we know that even divergent squints, particularly intermittent divergent squints, may be controlled if a good quality vision is provided to them, that is given them good proper glasses which they can wear, which improves the quality of vision, and they can control by fusional vergence. Always check for amblyopia. You must treat amblyopia before you plan for any surgery, unless of course there is a strong restrictive strabismus and the eye cannot come into primary position. And always treat amblyopia appropriately in the best options that are available for the particular age. Sometimes acquired lesions are missed or acquired squints are not picked up, and they may be because of orbital lesions and orbital disorders. So this was a case of an acquired Brown syndrome, and you can see very clearly it was because of a cyst, a well-defined cyst in the superior oblique muscle belly, and that resolved just by medical management. Always ask for and beware of variability, the history of diurnal variation if it is present. Always do an ICE test, or if possible, a neostigmine test, and of course the patient can just require medical management and no surgery is required. When you are deciding your surgery or when you plan your surgery, be sure of your diagnosis. Observe all the signs carefully. Like in this case, referred like a case of left 6 nerve palsy, but you realize the amount of retraction and the widening of the palpebral fissure and the discordance between the amount of deviation in primary gaze and the abduction limitation. So this is not a case of 6 nerve palsy, and this was a case of Duane's retraction syndrome. And you need to be very careful when you make your decisions, and you need to differentiate between the two. Pseudo-esotropias are important to be ruled out because you cannot operate, or you should not operate on them. From the far, this child looks like esotropic, but the moment you see the corneal reflexes, you know that the light is well centered, and you can of course confirm by a cover test, as Dr. Siddharth has talked about. Other factors that affect decision making include an angle kappa, adnexal relationship like epicanthal folds and hypertelorism that can affect a pseudo squint. Versions and ductions look for limitations. If there are any limitations, they need to be corrected intra-op. The first duction test must be free at the end of your surgery. Do it pre and post-op. Of course, your planning will depend upon what is your the state of the patient, whether it's a cosmetic outcome you're looking at or a functional outcome, and associated oblique overactions that Dr. Jyoti has talked about. So you need to have a comprehensive plan for every problem or every issue that is there in the patient. We know that graded recessions are the ideal for recti muscles, and even we prefer graded recessions for oblique. You know that there are hangback and adjustable and slanting recession modifications that are there for recti. There are limits for recession. You should not operate for less than a minimum amount because it's ineffective, and more than the maximum goes beyond the arc of contact, and the muscle, the effect of the muscle is significantly lowered, and it causes limitation of movement in that case, and therefore it is an undesirable outcome of a comitant strabismus surgery. Of course, these limits are essentially for a comitant strabismus, and they may differ if you are operating on an incomitant strabismus. So if you excessively recess, you can cause significant palpebral aperture changes. The vertical recti can cause palpebral fissure changes or lid retractions, undercorrection of the muscle, decreased excursion and saccadic velocities. Strengthening procedures essentially include resections, recti resections, and plications, which are an increasing alternative, which is fast and reduces the amount of bleeding as well as inflammation. If there is very pure residual action in one of the paralyzed muscles, then you may require a transposition procedure, because any amount of resection is not going to bring back any amount of force in a muscle that is absolutely dead. Again, there are maximum and minimal limits for resection. Below the minimum amount, again, the effect is very minimal, but the maximum limits are very important to know, because if you go beyond a particular amount, you're actually cutting muscle fibers, which also add on to weakening of the muscle and may not add to strengthening of the procedure that you're doing. So it's very important to remain within the limits, particularly for resection. There are gross nomograms. Different books have different nomograms given, and different surgeons follow different nomograms. But this is a gross nomogram that is widely accepted. But over time, as your surgical skill and surgical experience goes, and based on your outcome, you could adjust these nomograms a little mildly to kind of affect or see the effect on your surgical outcomes. Bilateral recessions versus unilateral resect procedure, the major difference is there is an additive effect for a resect procedure. And of course, under local anesthesia, only one eye needs to be blocked. But of course, bilateral recessions are reversible and has less bleeding. And also the palpable fissure changes are less. And therefore, the patient does not come back again and again that one eye looks smaller. Cosmetically, of course, that makes a lot of difference. The important points are that recession is stronger than resection. The response to the medial rectus is more than the lateral rectus in a ratio of 3:2. And of course, that gives us some varying amount of effects. You can get 25% more effect if you operate one eye, and you can get 25% effect in infants. And up to 10 years, you can get about a 10% more effect than you get in adults. Again, the important point is do not induce incompetence, which is particularly created if you do supramaximal surgery. Large amounts will cause duction deficiencies, palpable fissure changes. Divide the surgery between two eyes if it's a very large angle strabismus, and be consistent in your surgical planning. The other factors affecting would be age. We talked about it being more effective in the young. Patient's response can be variable, and if it is an unusual response in the other eye, you have to kind of grade that or use that when you're planning the other eye surgery. There may be anatomical variations of the muscles. Previous surgery makes a lot of difference, especially if you're operating on a previously operated muscle. Larger deviations cause more response per millimeter recession or resection. Therefore, it is not the same effect if you are operating for 70 plus prisms and for 20 to 30 prisms. So it's important to know that lest you get an overcorrection. The sensory state of the patient, whether there's binocularity, you want to overcorrect or undercorrect, which is basically your desired plan, and of course, unilateral versus bilateral surgery. Always be consistent as a surgeon where you place sutures, where you pass them on the sclera, where you hold the muscle stump, how you measure. You should be always perpendicular to the limbus. So these are key factors. Always be consistent. Otherwise, these will be the things that cause a variable outcome in your case. And the amount of dissection, always be just dissect till the place where you want to pass sutures in resection, or you want to recess the muscle in recessions. Do not dissect too far back, which may cause increased fibrosis or bleeding. There is a different choice between limbal or phonics incisions, essentially the same. I prefer phonics incisions for almost all my surgeries, except if there is a tight force duction test where I believe I may require to actually recess the conjunctiva also. Other than that, except that the phonics is a technically little more challenging, you need a very good assistant, but it of course decreases the amount of
time up, sir. Apologies. Next 30 seconds, if you could sum it up, sir.
Yeah, so you do not have much difference in outcomes. And finally, of course, as we'll be talking about the various kind of surgeries, the final decision that we make, A and B pattern measurements has been talked about, and Jyoti has actually talked about how you're going to alter your surgery for A and B patterns. So although things can be confusing if you come across a difficult case, there is no alternative to good workup, correct diagnosis, and realistic expectations. Thank you.
Okay. Thank you, Dr. Rohit. It almost took me back to my senior residency times. Those pearls were true even then and now and forever. So now we have Dr. Reena Gupta next. She will be talking about management of intermittent exotropia. Dr. Reena Gupta, please.
Is screen visible?
Please,
Not yet.
First one, open PowerPoint, then go to.
Yeah, I've opened. Just a second. Is it visible?
Yeah, but it is more or less blank. You do have a pointer there with this blank screen.
Just a second. Is it visible?
No, the
Not
presentation is still not visible.
You could just unshare and reshare the screen once, Dr.
Yeah,
Reena.
that's what I'm doing.
मैम आपका पावर पॉइंट ओपन है
हाँ, the PowerPoint is open.
शेयर कीजिए मैम तो पावर पॉइंट वाला विंडो चूज कीजिए आप शेयर करने के बाद जैसे शेयर करेंगे ना चार
Project.
Is it done?
ना मैम आप व्हाइट बोर्ड शेयर कर दे रहे हैं मैम
Screen is still blank.
What we get is a whiteboard and a sketchy pan kind of thing, which can write probably on that whiteboard.
Yeah.
So you need to kind of share the.
Nikhil, guide her. Nikhil.
There
tell
is
her
one.
1, 2, 3.
Yes, Atul from our team is actually looking into it. I'm here.
Please tell her 1, 2, 3. What to do? Nothing. That 1, 2, and 3 steps.
So
That's
first
it.
thing, as Atul said, you have to keep your presentation open, ma'am.
That's one.
Or you can also close it and switch it on again in case if it sometimes it hangs and it does not work.
Yeah, maybe I'll open it again. I think
One question,
Yes.
ma'am. Are you using a MacBook or are you using a Windows laptop?
it's MacBook.
Okay. Atul?
It's on the screen. So should I switch to the slide mode or just on the screen I open?
You can just open it on the screen also, is okay, ma'am. You don't need to go
No,
on the
but
slide.
did you have given this permission to the Zoom to allow sharing? There's an option to give a permission first.
No, I have not given permission.
MacBook, I don't
Just
know.
ask her actually.
Yeah, even MacBook, Atul would be the right person. Atul, आप हो यहाँ पर ना?
हाँ जी हाँ जी
Atul, can you just help me? See, first I have clicked the share screen and then I'm going to the presentation. Should I open the presentation first and then share screen?
यस मैम पहले मैम ओपन कीजिए पावर पॉइंट में
PowerPoint open है.
तो आप शेयर कर रहे हैं ना आप तो शेयर करते आप दो विंडो दिख रहा होगा मैम एक व्हाइट
हाँ.
बोर्ड और पावर पॉइंट वाला चूज कीजिए आप
I've done. Now is it visible?
यस मैम
Yes. Now, welcome.
Thank you. Thank you so much. Thank you, Dr. Rohit sir, for this opportunity. I'll be talking on intermittent exotropia. As we see, around 90% of the patients of exotropia which we see in our clinic, they comprise of intermittent exotropia. Burien classified intermittent exotropia into 4 main types, depending upon the amount of deviation at distance as well as near. This classification was modified by Kushner as he introduced the term proximal tenacious fusion and high AC by ratio. And he said this distance near disparity is basically because of these two conditions. And we often see that 40 to 60% of the patients of true divergence excess, these patients have high AC by ratio. And these are the candidates who can develop consecutive esotropia for near after surgery. There are 4 phases of intermittent exotropia. When should we intervene? We usually intervene when the patient is in the 3rd phase, when there is atropia which is there for distance and the binocularity is affected. How should we approach these patients? Usually you see that it's a variable age group. Even infants can present with intermittent exotropia. You can see it in the first 5 years and also in the first or second decades. Usually these patients are asymptomatic because of suppression, but asthenopic symptoms can be seen in the early stages, and also sometimes they present with intermittent diplopia or the closure of one eye in a bright light. Avoid diplopia is a very common presentation. How do we assess the control? Usually when these patients come to a clinic, we do the office control. We look whether there's a spontaneous presentation of the strabismus, whether it manifests spontaneously or it manifests only on occlusion. If it manifests only on occlusion, is the refixation there? And if the refixation is present, then whether it's immediate or it's after blink. And accordingly, we grade it. Then home control is done by the parents or the guardians, and they look what is the frequency of the manifest squint, whether it's less than 50%, more than 50%, and whether it is for near or for distance. And then we add the total score according to the Newcastle's updated scoring, in which the score is from 0 to 9, and 9 is considered as the worst. For objective assessment, we record the distance and near stereopsis. Of course, distance stereopsis is much more meaningful because this is the first to be affected. Then comes the ocular deviation. The recording of the accurate ocular deviation is a challenge because in patients of intermittent exotropia, variability of the angle is very common. And so there has to be a prolonged Cover uncover test, multiple passes have to be there. You have to take the endpoint as a reversal of the movement, and the target has to be the far target, the maximum distance which is possible, because that helps us to reduce the variability and uncover the full angle of deviation by reducing the near convergence. If we find there is a distance near disparity, we need to do a patch test for at least 45 to 60 minutes. Earlier, it was said that you have to patch one eye for 24 hours, but then studies found that it is almost effective if you do it for 60 minutes as well. But still, I patch the patients for 24 hours if I feel that the variability of angle is too much. And once we have done the patch test, we remove and measure the deviation at near again. And then it is followed by recording of the AC by A ratio by using +3 lenses for near deviation. This is how we do after the patch test, and then this is followed by recording of the high AC by ratio by using +3 lenses using the gradient method. This is how we do the gradient method. Then we look for a pattern by recording the deviation in different directions of gaze, because sometimes there's inferior oblique overaction with the V pattern and superior oblique overaction, which coexists with intermittent exotropia. In such conditions, we need to do the oblique weakening surgery in the same sitting along with the horizontal surgery. So the natural course of intermittent exotropia remains obscure because we don't have retrospective studies with long follow-up of untreated intermittent exotropia. Von Utten found that out of 75% patients, 50% of the patients progressed in the form of increase in the size of deviation, or the manifestation can be much more frequent, or you can develop a secondary convergence insufficiency or loss of stereopsis. So in these, so how should we proceed? If we feel that the angle of deviation is small or the control is good, in those patients, we can try non-surgical treatment in the form of part-time occlusion. It has been seen if we occlude the dominant eye or alternate patching, if it's an alternate fixation for 4 to 6 hours for 6 months, then it helps in reducing the angle of deviation and also controlling the fusion. Over minus lenses from -2 to -4 can be prescribed in patients who have high AC by ratio, and prisms in the form of basin prisms can be given to strengthen the fusion. This can be given pre-operatively as well as post-operatively. Convergence exercises have a role in patients with convergence insufficiency who have a near point of convergence. Anti-suppression exercises should be started in children who have a suppression scotoma. But as strabismologists, we believe that we need to intervene surgically at one point of time to improve the ocular alignment and to maintain the binocularity. How early can we operate? Can we operate less than 4 years of age? Jampolsky always said that we should wait till 4 years. The reason was that these patients have excellent stereopsis and in good intermittent fusion. So if we overcorrect, then they will land into monofixation syndrome and amblyopia will develop. So keeping this in mind, less than 4 years of age, we should intervene only if there's a rapid loss of control. Otherwise, we can do a part-time occlusion patching and defer surgery. Let them be more than 4 years of age when we can get accurate measurements, and then we intervene. The type of surgery, like Dr. Rohit already discussed, that bilateral LR recession is always a symmetric surgery which is preferred. For divergence excess and convergence insufficiency, we go for a bilateral MR resection. But there is a different school of thought for pseudo-divergence excess and basic. We can do R&R or we can do a bilateral LR recession. But personally, I feel if you have an angle of deviation less than 30-35 and there's a good control for near, then symmetric surgery should be preferred. A very important part of management of intermittent exotropia is long follow-up. You have to see whether the alignment remains stable, there's improvement in binocularity, or there is a residual exotropia which is there. If there is a residual exotropia of around 15 prism diopters even after the end of 6 to 8 weeks, usually we need to reassess, because these patients will find that the angle keeps on increasing. Or if there's a second situation, you see that the patient has developed a consecutive esotropia, though we always aim for around 10 to 20 prism diopters of overcorrection when we are operating, because there's a tendency of exotropic drift which is there. So in these patients, you just keep them patients for follow-up. It usually spontaneously it improves with a span of 6 to 8 weeks. If the patient has good fusional convergence amplitudes, you can prescribe a few exercises or you can restore to patching. So take-home messages: intermittent exotropia is a progressive disorder. So close follow-up of the patients, especially in the early phases when the control is good, is advisable. Preoperative deviation value and accuracy of method used for measurement is most important determining factor for successful surgical outcomes. Surgical treatment to correct the deviation and vision therapy to improve the binocularity is the preferred combination to treat intermittent exotropia. Thank you for your patient hearing.
Thank you very much, Dr. Reena. That was an excellent and a very comprehensive presentation. It's a pleasure to now invite the next speaker, Dr. Manjula Jaykumar from Chennai. Her concepts and her advice in the WhatsApp group for management is always very interesting and very enlightening. Dr. Manjula, please.
Thank you, Dr. Rohit. Am I audible, Rohit?
Yes, yes, Dr.
I'll share my screen. Is my screen visible?
Yes,
Is-
yes, it is.
Yeah, okay. Thank you for the opportunity. I would like to thank DOS as well as Dr. Rohit. Today, my talk revolves on how to handle accommodative esotropia. Well, before I go on to the talk, I would like to mention the two special attributes of accommodative esotropia. It's the only strabismus which is amenable to non-surgical management. It's a very common form of strabismus that is encountered in general practice. In fact, it is interesting to know that it is much more common in incidence than infantile esotropia. Almost 1/3 of our patients with esotropia fall into accommodative esotropia. And before we go on to the management, let us define accommodative esotropia. Accommodative esotropia is that form of esotropia which is partly or only contributed by accommodation because of the presence of uncorrected hypermetropic refractive error. Okay, so what are the different types of accommodative? The first type is the refractive esotropia or fully accommodative esotropia. The second type is that is caused by high AC by A ratio, which is the presence of esotropia only for near. Then you have a combination type where there is significant hypermetropia as well as significant high AC by A ratio. So still there is a near distance disparity, but there is an esotropia which is present both for distance and near, and an infantile accommodative esotropia, which has its early onset and it's also marked by the presence of inferior oblique overaction. So before we go to each one of the types, let us look at, if you have a patient with accommodative esotropia, what are the essential things that you have to measure? The most important thing is find out the complete amount of hypermetropia. That you're going to do with cycloplegic refraction. Next, you're going to assess the AC by ratio, which can be done by heterophoria or gradient method. And then you have to grade this distance near disparity as grade 1, 2, or 3. How do these children present? You see esotropia when the child fixes at near. The esotropia is essentially intermittent first, then it becomes constant. Fatigability will increase both the frequency and duration. There is often a family history which is positive. It can be manifest after illness or trauma, and sometimes it can be present even without any precipitating stress. So what are the different types? First, let's look at refractive or fully accommodative ET. The mean age of occurrence is 3.5. The mean hypermetropic refractive error is 4.5 diopters. The AC by A ratio will be normal. These children need to be given just hypermetropic refractive correction. They fully respond to hypermetropic refractive correction. The next type are the ones with high AC by A ratio. The age of presentation is 2.5. The refractive error is either low or normal for age, that is the hypermetropic error. These children are orthophoric for distance, but as you take the target closer and closer to the eye, you find that the near deviation increases or distance near disparity is present. So these children need to be treated with +3 glasses or bifocal glasses. The next is the combination type where there is a significant hypermetropia, and this hypermetropia, when it is corrected, the child is ortho for distance. But as you look, this child will have an ET despite the hypermetropic correction for near, which means there is also high AC by A ratio. So this has to be corrected with hypermetropic glasses with bifocal correction. Then you have the infantile accommodative ET, where ET is going to be present early in life by less than 9 months of age. The hypermetropia is fairly high in range, and there is presence of inferior oblique overaction. Okay, each of these different types of esotropia can also fall into partially accommodative ET when it doesn't get corrected completely with glasses. So what are the risk factors? Hypermetropia, family history, subnormal binocularity, anisometropia, amblyopia. So how do you go about treatment? It's a non-surgical treatment, as a huge road, so you have to prescribe glasses. Full cycloplegic refraction is given in the form of spectacles, but if the angle of deviation is small, you can undercorrect the hypermetropia. But despite compliance, if you still feel there is deviation, you have to increase it to full prescription. First visit, there is no bifocals. First visit, there is no amblyopia treatment. You give glasses, call the child for follow-up, and assess the baseline visual acuity and start on your amblyopia therapy. If there is amblyopia, patching or atropine penalization can be given. When you are doing atropine penalization, please do not reduce the spectacle power in the sound eye, because this is an accommodative ET. Now, how do you follow up with spectacles? 2 months with glasses, you check for alignment. If there is good alignment and there is no amblyopia, follow up every 6 months. If alignment is not okay, check for compliance. If compliance is not good, you can add atropine to improve compliance. If alignment is not okay despite compliance, look at cycloplegic refraction again. And then you have to change your hypermetropic correction if needed. If alignment is good for distance but not for near, you have to add your bifocals. And this bifocal should be set at the lower edge of the pupil. If the child is not compatible with bifocals, then you may have to consider myopics. Where do you give surgical treatment? Surgical treatment, if the alignment is not satisfactory with glasses, so all partially accommodative ET will need to go for surgery. Deteriorated accommodative ET, when there is marginal control, aligned for distance but not for near. Older patient where hypermetropia is normalized, but they still cross without glasses. One thing that you have to remember, surgery need not be deferred until amblyopia therapy is complete, because amblyopia benefits from improved alignment in accommodative ET. And this is the paper from in JPO's publication, which you can look into. So as far as surgery, so this is a child with bifocal. So we have done the angle correction, bimedial precision for near. We have removed the bifocals. You can operate on the near angle. You can add fade into your precision. You increase your surgical dosage by augmented precision rather than your standard surgical dosage to correct your deviation for near. So the other thing is, this child is a partial accommodative infantile type of accommodative ET. It has a fairly large ET. So you have to do R&R in this particular eye, and the inferior oblique overaction is dealt by inferior oblique recession. So if you have an amblyopia with a single eye esotropia, then you can do the R&R, follow up with amblyopia therapy. As I told you, amblyopia therapy can be followed up with surgical correction because it improves
1 minute remaining, ma'am.
Amblyopia therapy. So what are the long-term prognosis? Well, you have to give full hyperopic correction and bifocal therapy during their visually formative years. But does it mean that the child is spectacle dependent all the time? Not at all. Mohani et al. Have said that 20% of accommodative ET will be free from glasses from 10 years from diagnosis. Those who need long-term spectacles are those with high AC by ratio, high hypermetropia at presentation, anisometropia. And you can wean off spectacles when there is low hypermetropia, normal AC by ratio, or if you have undertaken surgery for correcting their deviation. So the last slide is, enjoy treating your accommodative ETs, and thank you very much for your patient hearing.
Dr. Ankur, you are mute.
Thank you, Dr. Manjula, for such a nice presentation about accommodative esotropias. And next in line, we have Dr. Sandra, and she'll be talking on acute comitant esotropia. So, Dr. Sandra, can you share your screen, please?
Thank you, Dr. Ankur. Are my slides visible?
Yeah, we can see you.
Yes. So I thank you a lot for this kind invitation, Dr. Rohit also. And today I'll be talking about acute comitant esotropias. As you can see in this picture, the boy on the top right, he came with a large angle esotropia just before the onset of the pandemic. And he was in his 12th standard and he was really incapacitated as he couldn't study anymore. Treatment, and then you can see the lower right where he is fully aligned and he aced his exam. So what treatment it is, I'll tell you towards the end of the presentation. So to begin with, you have to remember this acute comitant esotropia is very rare. It's one of the rarest form of strabismus that you would see in children. It's only around 0.3% of all, and it's acute in onset. It's a large angle, And usually it starts intermittently, and then later on it becomes constant. And it's usually seen in older children and adults, usually above the age of 5. So the classifications was given very early by Burian and Miller, and it came in the American Journal around 1958. And the classical types are the type 1, which is the Swan type, where you have interrupted fusion due to a monocular vision loss or occlusion that results in the esotropia. The type 2 or the Burian-Franchetti type, which is with a minimal hyperopia precipitated by a physical or a psychological stress. And the type 3 being the Wilczowski's type, which is associated with myopia and might result from excessive near activities. And there are certain other rare forms like the refractive accommodative type associated with spasm and intracranial disease. So the etiology, again, it could be due to uncorrected myopia, either too much of near activity. It could be a decompensated esophoria where initially the patient presents with progressive intermittent diplopia that dramatically converts into a large angle committant esotropia. And sometimes, very rarely, it is also associated with intracranial diseases like elevated intracranial pressures and other tumors including glioma, adenoid malformations, and so on, and which will require neurologic and neuro-ophthalmic imaging. So what do we note in the history? The age of onset of the symptoms and the duration of symptoms, whether the patient has constant or intermittent diplopia, the duration of near activity, detailed orthoptic, motor and sensory evaluation, ability to fuse with prism, and always exclude accommodative ETs by cycloretinoscopy if the hyperopia is high, first prescribe glasses. So the criteria is acute onset committant, that is the deviation should be less than 5 PD difference in all gaze positions with no or minimal near distance disparity. Always take a photographic evidence of the absence of strabismus before the said onset, normal motility and presence of diplopia. As I said earlier, again, there is a need for imaging. We do MRI in all patients because sometimes it can be associated with brain tumors. Many reports are there regarding associations with tumors, like even this interesting to note that Zweifach, he reported a 10-year-old boy who developed esodivation, had negative neuroimaging, successful surgical repair was done, but about 18 months after surgery, a medulloblastoma is noted. So perhaps these patients need to be on long-term follow-up even after you do the surgery. And if you presence of abducting nystagmus, it's an important feature to rule out a 6-nerve subtle involvement. So the spontaneous recovery is quite unusual. So the treatment would include spectacles if there is hyperopia, botulinum toxin, or surgical intervention for a good prognosis. And DDs include 6-nerve palsy, divergence palsy, accommodative esotropia, myasthenia, decompensated monofixation syndrome. The good thing is all these patients have very good potential for binocular vision because it's later in onset. So coming to the impact of COVID, we hardly used to see these kind of cases before, but with the onset of COVID, we were seeing more and more of these acute committant esotropias, much more than we saw previously. It could be because of probably insufficient time spent outdoors, excessive near work, which is already causing a myopia epidemic, and excessive near activity due to increased usage of tablets and smartphones. So the smartphone excessive usage is said to be more than 4 hours a day. And if in patients who are predisposed and they have a latent esophoria or poor divergence capacity, they may be predisposed to developing kind of a tonic activity of the medial rectus, resulting in a manifest esotropia as proposed by Wilczowski. So now I'd like to share with you what our experience have been with the use of botulinum toxin for acute committant esotropia. We had 18 patients, 3 before the pandemic and 15 after March 2020. The age distribution, as you can see, the initial is 5 to 24. We didn't see patients more than that. And the sex distribution, many of them are males. And most of them are from Kerala, a few from Tamil Nadu, bordering to our hospital. And the duration, all of them are presented very early in their onset. This is the y-axis is the months, and very few have presented later. But those are the patients who had intermittent diplopia and symptoms. And you can see the pre-injection PCT is around nearing 40, so it's a larger angle. Post-injection, on an average, it is around 10. And As you could see here, many of the patients were constant diplopia, around 28% were intermittent diplopia. Almost all our patients are hyperopic, only 2 of them are myopic, and more than 4 hours of gadget use has been seen in more than 50% of our patient group. So all these patients now I'm having a 6 months post-injection follow-up. Out of 18, I have 12 patients who have been completely cured in the sense that they have phoria and they have sensory stereopsis of 60. And the recurrence occurred in 2 patients where initially the angle became a phoria, but after 3 months it again came back. And the failed is where in 5 patients where the initial angle reduced by just, for example, if it is 40, it came down to like 25 or so, and again after 1 month it went back to the original value. So these are few of our patients. You can see here, Joel Manu came with a large angle ET in December. That was just before the pandemic, December 28, 2020. In July 5th, he still retains an ortho and has good stereopsis. Similarly, here, Fatima Rasha, who's a large angle ET again, at 6 months follow-up, does retain a binocularity. And so this is the record of all our patients that we have been following up closely, and I also intend to follow up them in future. So this is one of the recent patients that we gave just last month, and she is again just a college student. And these patients are really bothered by the diplopia, and the botulinum toxin injection, which I give, is mostly under topical for older patients above the age of 16. And in younger patients, I do it under short inhalation anesthesia. And it's a day care procedure. They go off immediately and non-surgical. So most of the
1 minute
patients
remaining.
are, yeah, it's almost done. So that's our experience. Thank you. And the first patient in the first slide, again, we gave Botox, and till now he seems to be fine. So it seems quite promising. And another thing I forgot to say, in all the patients that were cured, about 5 of them had the divergence insufficiency, which was found after the injection, and they are aligned. We do the binocular vision status assessment in all of them, and out of the 9 patients, 5 of them have divergence insufficiency. The others are okay. So all of them are on Broxtine right now. Thank you.
Thank you, Dr. Sandra. That was very interesting. Next, we have Dr. Savleen Kaur, who will be talking about imaging techniques in strabismus. Dr. Savleen, please.
Thank you so much. Thank you so much, Dr. Rohit, for having me here. Thank you, DOS. Thank you, Dr. Ankur. I find it a very comprehensive session, and I'll be concluding by talking about newer imaging techniques in strabismus. If my slides are visible.
Yes, Dr.
Yes.
Yes.
So once we are, I don't have any financial disclosures. Once we're discussing the imaging modalities in strabismus that we have, there are age-old technologies like fundus photography and, of course, neuroimaging, which are very useful and are here to stay and not to go. But we are talking about recent imaging modalities, so I'll be focusing on the ones that are less commonly used and maybe more upcoming. So I would start by describing a case of an 8-year male who presented with a right hypertropia. There was a limitation in depression, and the hypertropia seemed to increase on dextrodepression. There was an inferior oblique and a superior rectus overaction. There was no history of any trauma. There was no craniofacial abnormality, and the patient had a large intorsion. So we were kind of suspecting that there is something wrong with the inferior rectus of the right eye. And since IR palsy is quite rare, maybe it was an abnormal inferior rectus or an absent inferior rectus. In such a situation, we would like, as a strabismologist, if the imaging can help us tell where the inferior rectus is and how its morphology is. So when do we want to image muscle insertions? We have various technologies with us. And if I just recapitulate, the ultrasound biomicroscopy was described in the last century to image the horizontal muscle insertions as well as the vertical subsequently. We published that in treatment-naive or primary patients, this technology is very good, and it can accurately measure up to 1 mm, and its accuracy decreases with reoperations. So in cases like this, where we are suspecting muscle abnormality and treatment-naive eyes, this is a very good tool. but it's not very reliable when we are dealing with cases of reoperations or when we have larger and increasing distances from the limbus. More so, like in this case, this is a contact method. So in children, it might not be very good and very accurate because of the uncooperativeness of the patient. So we published our views initially on the AS-OCT in strabismus, which was found to be lesser invasive and quicker to image these insertion distances, especially in primary surgeries and also now in re-surgeries. It gives a better delineation, and the biggest advantage in children being that it is non-contact. So coming back to the patient where we were suspecting an abnormal inferior rectus in the right eye, we thought let's do an AS-OCT before we image with the neuroimaging techniques. So as you can see, the right eye is being imaged 360 degree in the inferior quadrant for the inferior rectus, and we couldn't find it up to 14 mm. In the left eye, of course, we saw well-defined hypoechoicity consistent with an inferior rectus at around 6.6 mm. So we did concur our findings on the neuroimaging, where we saw that the inferior rectus on the right eye was absent and the left eye could be beautifully delineated from anterior to posterior scans. Intraoperatively as well, where a normal inferior rectus had to be, there was an enlarged episcleral vessel. The other recti were normal, the superior rectus was tight, which was recessed, and we got a good postoperative outcome. This case actually highlights how a clinic-based test like AS-OCT could be done in cases where we are suspecting muscle hypoplasias or aplasias. And before we move on to more sophisticated imaging and more radiation exposing imaging techniques like the neuroimaging, we can do this technology in the office if available. The second case, again, where I think imaging these days is quite advantageous, is the case of a left exotropia in a young female who's already operated for squint in the left eye. So she's a case of ROP, which was lasered. So she seems to have a little bit of eccentric and maybe macular drag in this eye. That's why some amount of pseudo as well as true strabismus. So her deviation is around 65, and she does give us a consent for the other eye surgery. But a deviation of 65 might not be corrected by one eye surgery alone. So we thought, why not image the left eye and see whether we do have some scope of surgery in the left eye. In the left eye, we saw that the medial rectus was recessed to around 8.6 mm, and there was a band of fibers stretching to the original insertion of the medial rectus. And intraoperatively, we could corroborate there was a stretch scar from the original insertion to the medial rectus insertion site where it was recessed. So we advanced this muscle, plicated it, and we got a good postoperative outcome. And now the residual deviation could be corrected with the good eye surgery, and we can give a better outcome to the patient. We did not induce any additional motility deficit, and the imaging helped us to plan the surgery in the already operated eye. So in reoperations, again, the debate was whether to do the UBM or the AS-OCT, and we did publish recently in JAPOS that the AS-OCT seems to be better delineating than the UBM. You see this, the left images are on the AS-OCT and the right on the UBM. How beautifully the cleft between the muscle insertion and the sclera is seen on the AS-OCT image, and the identification is much easier and simpler. It's also quicker because it just takes 3 seconds, and it has the longer penetrating wavelengths. So larger distances are measured in one go, 13 mm and beyond. Sometimes you miss them on the UBM. Again, in presence of scar, sometimes this delineation is quite accurate on the AS-OCT with the overlying scar as well. And the spectralis also gives us very enhanced views, especially if we want to image reoperations and we suspect and we see scarring clinically over the muscle site. The SWEP source can, to my experience, image larger distances from the limbus and is my preferred choice in cases of reoperations. To conclude, amongst all the imaging modalities, if you are dealing as a strabismologist with a case of reoperation, that is where you would want to know the information on the muscle insertion. And I think that is where these modalities are invaluable to the surgeon. The UBM has some disadvantages. It's accurate as compared to the AS-OCT, but the accuracy goes down when we are imaging larger distances. The AS-OCT, we have published now that it's more comfortable, it's more quicker, and maybe more accurate in reoperations. I would like to conclude saying that we can use the most sophisticated instrument available with us, but not without a thorough clinical examination, because that is what will guide our ultimate strabismic plan. I would like to acknowledge Dr. Jasprit for all intellectual inputs on all my papers. And thank you once again for having me here.
Thank you, Dr. Savleen. Excellent presentation, especially very interesting papers also we've read. It's good. We also have been doing these techniques. It's the only thing is that most strabismologists in their clinic do not have access to these. So I would say that we are lucky working in,
Sitting in a tertiary and institutes, you do have access.
All the access to the wide instrumentation. Our anterior segment fellows, keep using, including even the retina fellows that we keep using the instruments for, particularly for neuro-ophthalmology. But yes, it's very useful when you are stuck and you're not sure. So just like you exemplified in the case where you do not know what previous surgery has happened. And that's what is our experience, that in many of the times we come across a patient who's been operated very long ago without any records. You probably may be able to identify.
Rohit, voice is a little low. Can you increase the voice?
Gone.
In a tertiary care center, but even for most strabismologists, you come across patients whose records have been lost, and we don't know what has been done. And these investigations can definitely help. Even if we don't have it in our own clinic, we can easily access them in a colleague's clinic, anterior segment clinic, and you may not require expensive imaging like MRI or CT. So that's a definite advantage. So let's take some questions from around the panel. We can start with any questions for Dr. Savleen, any a very interesting new technique. So any questions or curiosity that anybody has about these techniques that she's described? So Dr. Savleen, what are the problems in reoperations? Because that is one area where I have consistently had difficulty. So identifying the muscle, great. How accurate is it to measure if the muscle is recessed, to be able to know how much the muscle has been recessed preoperatively? Like suppose in your case, if I wanted to know if it's a residual exo, and I want to know how much a recession of the lateral rectus has happened previously, should I go in and re-explore, or I will have to operate the other eye, in which condition sometimes the patient is unwilling? So can I get a relatively accurate estimate of the position of the recessed, say the lateral rectus, or even the medial rectus, which sometimes I think is a little more difficult because of the structures there. But anyway, in your experience, any recti is more difficult or easier, and how accurate is it in recessed muscles?
I would answer your question in two parts, sir. For the recti, if I have to point one, because the imaging of lateral rectus is restricted by adduction, or by the nose. So sometimes when you have a recessed lateral rectus, and especially larger recessions, because it is at larger distance as compared to the medial rectus, it is difficult to image. But if I have to choose between vertical and horizontal recti, then definitely the vertical recti are the most difficult to image, because of the lid, and then you have to again touch, and the kid won't allow you to touch. So in children, I would say that the vertical recti are more difficult, and amongst the medial and lateral rectus, I think the lateral rectus, because of the increasing distance from the limbus and of course the adduction factor, it is relatively difficult to image than the medial rectus. The second question that you said, how accurately, I would say, if I have to take a number, I think 2 mm. So most of the recessions that even if you do not have any record, you would get an accurate assessment, say up to 2 mm plus minus from where the muscle is. So that's what my experience is. But I find it pretty useful, because if I'm planning a reoperation and I have an idea that within this distance, within plus minus 2 mm, I'll find the muscle, then I would, like to go in for the same eye. Of course, the motility of the patient will also tell you that what was the previous surgery, and if there was the motility is normal, then within 2 mm, if I'm more sure, and I would like to go in with the same eye before giving a chance to the other eye.
Please, ma'am. Yeah, so I want to check whether you actually have, say, you've recessed a medial rectus or a lateral rectus by 5 millimeters. Have you really gone back and checked whether exactly it's moved back by 5 millimeters? Have you done that in your cases? Like you operate pre-op, post-op, first day, and 2 months, to see that it's how accurate it is?
So
Where you
with the with the UBM, the paper that we published was actually about this only. Preoperatively, we imaged the muscle, then we did the surgery, and 1 month post-operatively, we imaged the same muscle. So we were sure that we were operating, this is where we had put the muscle. And of course, we tried doing that in plication as well. And out of the 25 that we did, I think 1 we picked up where the muscle had kind of slipped where we had intended to. It is limited by the post-operative edema, because up to 1 month or so, we are not very accurate with the measurements because there is post-operative overlying edema over the muscle. But yes, we did that in our cohort because on reoperations, you don't know, but when you are doing treatment, naive patients, and then you see them again. So these instruments are quite accurate.
Do you also get an assessment of the thickness of the muscle? Now, so for example, if it's a thyroid ophthalmopathy, we do a neuroimaging basically to look at the thickness. So will this ASOCT or UBM also pick up the thickness of the muscle that's in question?
It does pick up, ma'am, but it is only the anterior part of the tendon that you're doing. So it might not help you in cases of thyroid. People have done it. They are documenting thickness on the ASOCT as well. But to my mind, sometimes the anterior part of the tendon is spared. So you might not be able to go that posterior where you actually want the thickness of the muscle being affected in thyroid. So I don't prefer it. I mean, I can do it, but I would still want to neuroimage to be sure.
I think, as Dr. Savleen is saying, it would be extremely unreliable to base your diagnosis on just ASOCT or even UBM, because essentially you will get the tendinous part of the muscle imaged and not the posterior part where actually changes happen and where there is actually doubt. So you are in very early cases where there may be very mild thickening, which may be picked up in your cross section on a CT or an MR, but on the ASOCT or even the UBM you may not get. Let's move on to the next topic. I know this is extremely interesting, that the few technological advancements that we get in our specialty, but let's move on to
one question. One question I have.
We'll come back. Let's have the other very, very important topic, which Dr. Sandra spoke about, which, within the epidemic, it's like an epidemic for us, is the acute comitant esotropias. And I'm sure all of us have really seen an upsurge in acute comitant esotropia. In fact, one is actually deciding whether you need to, neuroimage these children, because you're almost virtually sure it's related to the massive increase in the device use that these children are having. But I, for one, have not been, had the courage to not image them at the moment. But, that's a thought. But I'm sure other experiences, we just go around, Dr. Savleen, Dr. Jacob, Dr. Manjula, Reena, everybody would have had a real upsurge in the acute comitant ESOs that are presenting among children for us. Savleen.
Yes, I completely agree. There is an upsurge, and maybe we are seeing them more because it's happening more, or we are just, because of the increased awareness is coming more. I don't know. I don't have that answer. But yes, like you said, my threshold of neuroimaging is quite low because I order it in the first go, because I still don't want to, put it into one category and leave them not imaged.
And as practitioners, we have to order. I mean, we just can't not order it.
So as a clinician, I would say that at the moment, it would be unethical not to first do an age-appropriate cycloplegic refraction and subsequently neuroimage them, if of course there is no accommodative element, as was pointed out. My only difference of opinion with Dr. Sandra would be that, we have surgically intervened, and botulinum toxin, as was being introduced for infantile esotropias, we saw that there were multiple injections. In fact, Alan Scott's paper, initial ones, talked about 3 to 4 injections, a mean of 3.5 or so, for every child who Botox was used for this correction of infantile ESO. So you were able to correct all of them with a single injection, and do you inject in both medial recti or one of them?
No, sir. We injected only once. I injected all patients only once. And the dosage was from 3 to 6 units, the maximum of 6 units into the medial rectus. Probably, and we did not have to, like, if they are responding to the treatment, I can see that at 15 days. So when they come for the 2 weeks review, they are completely straight. So that's what I wanted to share with the panel, that it did not need multiple injections.
Sandra, don't you see an exotropia before they become straight? Because generally, after the injection, they have to go into a period where they become exo and then they align. It is
Actually,
not
that's
like
what was
ESO
described.
becoming straight.
That's what was
That
described.
doesn't
In fact, was the desirable outcome in the infantile esotropia study, that botulinum toxin is long-term better results if there is an initial overcorrection and then over time they come back and become aligned. So
And these are larger angles also, Rohit.
Yeah.
Since it's larger angles, even I have had, last year alone, I've done about 10 cases of acute onset ET. And all of them have been surgically addressed and not botulinum toxin.
Yeah.
I would rather reserve botulinum toxin only for traumatic LR paresis. Because I'm using it at present only for traumatic LR paresis and not for acute onset ET, because the results are very good and they get binocular vision. This is one condition where you can restore binocular vision if you do surgery early on. So I would not, in the thing, put off surgery and give Botox and have a variable result. And by that, putting off binocular vision for these patients.
So I think, we'll just interrupt this for a minute. We have Dr. Namrata Sharma, the Secretary of Delhi Ophthalmological Society. And I, of course, want to thank her for giving us this Pediatric Ophthalmology and Strabismus Subspecialty Day, giving importance to our specialty, which is rather ignored, considering she's a leading cataract refractive cornea specialist. So thank you, Dr. Namrata. A few words to the panel here.
Rohit, it is the other way around. I have to thank you for making this session and for getting such illustrious speakers on board and for such great discussion. So thank you very much for doing it and for sparing your time and for your contribution. Thank you. I just wanted to say this.
Thank you, ma'am.
very much.
Thank you.
Thank you.
Yes. So any other comments? I mean, I would agree with Dr. Manjula. We are very, very reluctant to use Botox for strabismus. It's an interesting experience. It's always good to have a different surgical interventions, and this only teaches us that you can reach your goal by multiple routes, and none of them is correct or none of them is wrong. So it's like experience and time that will tell us which may be a more desirable way to do. So any other comments, Dr. Digvijay?
Dr. Rohit,
Dr. Reena, yes, sorry, sure, go ahead.
I just wanted to say, like, recently we are all seeing these cases of acute comitant esotropia, and surprisingly, most of them have very large constant angle of esotropia. So when do you go for surgery in these cases, and what is the first line of management which you're going for, like when such cases come, and your take on that?
So let's have Dr. Sandra give her opinion on her, other than Botox, before she intervenes and time when she plans, and of course, other interventions. Dr. Sandra.
Sir, the reason why we are giving Botox, because I don't do surgery very early. So in case the patient comes at the age of 5 or 6, sometimes we are seeing in this pandemic, the patient coming very early on. Smaller children because of online activity or so, compared to what we used to see earlier. So in case the child is in the amblyogenic age group, that is less than the age of 8, so when would you actually take the patient for surgery? Do you go for very early surgery? Because if we keep waiting for 6 months, they are going to lose binocularity, and that is one of the main reason why I started on this. And the technique is entirely injecting, like, without opening the conjunctiva. So probably I think that's why we are getting results with just a single injection. There is no extravasation. The injection, the entire quantity of whatever injecting is going into the muscle sheath. So with experience, you can get it. It's not impossible. But maybe that is the technique may be changing between the people, and that may be the reason for multiple injections and single injections, in my opinion. So if the child comes very early, then definitely they will lose binocularity by 6 months, as we traditionally wait before doing in an acquired case. So I am not doing surgery before 6 months. I am doing surgery in the cases where they do not align well after the botulinum toxin, explaining to the parents in every single patient that this may not be a final cure, but in spite of it, they are willing because it is not a very experimental therapy or anything. We have been getting good results with it, and I'm working on publication of the data. In fact, there is a paper by Dr. Hunter who in 2017, in which he has done a retrospective review of, I think, 60 patients or so with botulinum toxin injection in acute comitant esotropias, where he also has got very good results. So I think it entirely depends upon the person, and they can decide whatever is comfortable with them.
Sure, absolutely. I mean, I don't disagree. Absolutely, like I said, there are many ways
I'm
to
not a
use that.
squintologist, but my query that this corona caused this thing, acute onset thing, and which was their non-corona thing. How you differentiate and choose the treatment?
No, so I'll come back and say that while we keep mentioning that it is part, I mean, it's seen increasing in the pandemic.
It's definitely being seen more,
Thankfully,
but
it has
how you
nothing to do
differentiate?
with the infection. So none of these children have the infection. The essential concept behind this is that
No, it's not.
there
It's
is no
sorry, not
classification
infection.
per se. And I'm just coming to the
Sorry,
basic
Rohit, not
pathophysiology
infection.
behind this.
Not infection, for the mobile, for
Yeah,
the corona.
exactly. That's
not
what
going to
I'm just
school.
coming to. The basic pathophysiology behind this is that in the Franchesity Burien type, essentially what the basic concept for that is that when the child is having fever or is unwell, times of psychological, physical stress, essentially the vergence mechanism, the fusional vergence mechanism is overwhelmed. So in these conditions, in the present circumstance, because of the chronic near work, the fusional divergence, which is essentially always weaker than the fusional convergence, is kind of overwhelmed. The eye is not made for near work for long hours of 6 to 8 continuous long hours. So the fusional, there is a fatigue of the fusional divergence mechanism, and therefore these children who may actually be esophoric to start off with may have very mild hyperopias at their age. They actually completely break and they manifest the esotropia, and almost all of them would require surgical correction. They are unlikely to correct now spontaneously. And as for the timing of surgery, like I said, the key steps always age appropriate cycloplegic refraction, rule out a space occupying lesion that we still cannot say for sure it is not there. And then I generally tend to operate between 2 to 3 months, from the time they precipitate, basically having 1 or 2 follow-ups with essentially stable angle. The youngest I have operated is a 3.5 years old, unfortunately showing the massive increase in the near devices that we are giving our children. So I would say that yes, as Dr. Sandra is saying, operate early. You need to intervene early, otherwise you'll lose binocularity. And in the waiting period, I would tend to give 1:1 occlusion because I do not want amblyopia to develop in that period. So any other thoughts in that about that?
Any role of giving long-term, maybe 15-20 days of atropine to these people? Because I have seen like you have +1 or +1.5 of hyperopia, which we don't actually think is causing so much of esotropia. But in these patients, you preferably give them these glasses, say +1 also, and give them atropine alternate night for say 10-15 days and then call them back again in 20-25 days. So sometimes they do get kind of aligned, some of them.
I don't know, no experience,
Maybe,
and I would
maybe
not
it's
see
because of a
why
lack
they
of
would.
activity because of atropine. I don't know.
That
No,
may
I
be
have tried
possible.
atropine, but they're not responding. They're not responding.
give
So I think large angle.
Yeah.
I think they're very large angle
large
will
angle.
respond
Very
to
large angle,
atropine and
Rohit, if your explanation of the etiology is like this, then the toxin is much more useful because it's a temporary thing. This phase will be gone after 6 months, then they will be okay.
No, but that's, like I said, the fusional vergence mechanism, once it's broken, does not come back unless you align them. And maybe over long time, we will see what has happened to their long-term binocularity, but then this will never return. It does not return even if you wait for 6 months or longer. So
No, with
one
this
intervention is required.
botulinum, with the botulinum. As
No,
Dr. Sanders
botulinum goes
showed.
away. I'm surprised, like I said, I'm surprised about but possibly, again, I agree with Dr. Sandra that a single dose, once you bring alignment, may be possible in long-term alignment in these children. The possibility is because this is actually a subset very different from infantile esotropia,
Yes, that's the thing.
who do not have any binocularity to start off with. So in this group, maybe I think Dr. Sandra's
I think
you know, they
I go
develop
with Dr.
alignment,
Chandra.
and
Yes.
the fusional versions comes back to the active, and therefore they may get long-term alignment despite the
go with
botulinum
Chandra.
toxin losing
Yes.
its losing its efficacy over a month or so, over 6
One
months.
more point that I would like to add, Rohit. I have also operated on every one of my patients, not used botulinum toxin. None of them have developed into an exotropia. If you do a good workup, rule out an accommodative element and neuroimage. I have not actually neuroimaged every one of them. There I've been sure. Neuroimaging, if you have a little lateral incompetence, or if you see a disc edema or disturbances in gait, if you have other things concomitant, I think you have to do. I don't think so. Every case of acute onset, if you have a strong suspicion of a neurological disorder, then you can image. Otherwise, I think you can wait also. If it's fairly comitant and you feel it exactly behaves like an acute onset comitant ET, then I don't think so there is a need for neuroimaging either in these patients. That's my personal opinion, but I think there could be different things. And none of these patients have gone into a consecutive XT either. Because we have a follow-up of a year now. All those 10 cases or 12 cases which we have done, we are following them. And the youngest was a Kashmiri child who's, glued to the mobile phone, doctor parents, they're completely apprehensive. And, we had people recommending them, okay, how was the surgery? So much of pressure on this kid. And he was completely aligned. Now it's 6 months since I'm following him up. And there is no XT. Your angle should be, and let me tell you, you have to take R and R. You cannot do this like infantile ET doing bimedial recession.
Okay, no, I do. My experience is bimedial recession, so I always prefer in children to do bimedial recessions. And
to strengthen your lateral recti.
No, I don't think so. I don't think that. Again, like I said, they have baseline binocularity. So
it's one eye which is always converging all the time. It's one eye which has gone into ET. So I have done an incomitant surgery.
A resection does not in any direct way.
No, at least when your angles are big. When your angles are big,
yeah, that may be true. But then we get very good results by bimedial recessions, even in infantile ESOs, which have very large angles.
Yeah,
and anyway, these discussions are endless. We have Dr. Pradeep Sharma of the next session here, and our speakers of the next session are here. So thank you very much. These discussions can keep going on, never ending. And the strabismologists essentially are.
Chandra, I'm with you.
Are part of the argumentative Indians, because we also have much less to do than our most, anterior segment surgeons. So thank you, everybody. Thank you very much. Thank you, DOS, for the opportunity.
Yeah.
Welcome to the next session.
Thank you, Dr. Rohit, and thank you, DOS.
Thank you.
All the best.
Thank you.
Welcome, Dr. Pradeep Sharma, the
Yeah, good
chair
evening,
of the
sir.
next session.
Thank you, Rohit. Yeah.
Good evening, sir.
Good evening.
Namaskar, sir.
Dr. Subhash, the president, is here of Delhi Ophthalmological Society. Thank you, Dr. Subhash, for the opportunity to hold this pediatric ophthalmology and strabismus subspecialty.
Thank you so much. On behalf of the organizing committee, I would like to thank Dr. Rohit for finishing it on time, sir. We finished it 3 minutes before time, and we have our chairperson for the next session also present with us. With the permissions, can I get started with the next session?
Yes.
I would request the chairpersons to please unmute themselves and switch on the camera, starting with our chairperson, Dr. Pradeep Sharma, sir, our co-chairperson, Dr. Subhash Dereya, our conveyor, Dr. Ajay Agarwal, our co-convener, Dr. Sumita Agarkar, our moderator, Dr. Anirudh Singh. Over to the moderator.
Unmute yourself, Anirudh.
Anirudh, sir, if you could just unmute yourself. Yeah.
Thank you. So I think most of the speakers are already joining now, and we would be having a really complex strabismus situation made easy because of the speakers, starting with our doyen of strabismology, our very own Professor Pradeep Sharma, sir, who would be starting with the surgical pearls. And let me tell you, his pearls are really, precious, and I've been treasuring them for quite a long time. So over to, without wasting too much of time, I will start off with the first lecture, which is by Professor Pradeep Sharma on surgical pearls for complex strabismus.
Thank you, Dr. Anirudh. It's a pleasure to see you again after a long time. It's been a pleasure to see all of you. And I would once again thank Delhi Ophthalmic Society for organizing this DOS special international meet, which is there. And to all my panelists who are there, I would like to begin this talk with this topic. And this, as you all know, is on complex strabismus, and there are very nice talks which are lined up. So I would now restrict only to third nerve palsy, because I see the other topics are going to be covered by other esteemed speakers. So on the surgical pearls in third nerve palsy particularly, let me focus. The challenges that the third nerve poses is really unique, because it is one of the most complex strabismus that we see because of its supplying all the extraocular muscles except for the lateral rectus and superior oblique, and even the internal ophthalmoplegia can be there, and even the LPS is involved. But the simplest way to tackle them could be if the eye crosses the midline, like in this case we see preoperatively. So first of all, whenever you have a case, you would have to wait for the investigations. So that I'm not going into it, because we have to go to the surgery. We usually wait for 6 months for the things to resolve, or the investigations show us any neurological thing, then we need to evaluate that. And never forget to see for the papilledema or the fields in any case of paralytic strabismus. But once you have zeroed down to doing a surgery, then we are going to observe what is the deviation in the primary position, how much is the incomitance, and does the eye cross the midline. Now, if the eye crosses the midline, then we may get away with doing a recession and resection, like in this case. And as you can see, the primary position has got corrected. There is some improvement in adduction. Because it's a paralytic muscle, the patient has to be told that there would be a limitation in adduction still there. Nowadays, we are more and more focusing on plication, and in paralytic strabismus particularly, plication has an added role, because you will be sparing the vascular supply. So in future, if you need to do a VRT, a vertical rectus transpositions, then you can easily go ahead with. Now, this individual, who happens to be a doctor himself, had a road traffic accident and he developed a third nerve palsy, as you can see here. But in this case, it is just touching the midline, and I took the opportunity of trying the maximal recession of the LR. Now, mind you, when we do FDT intraoperatively in these cases, we may have to do large recessions than what we are conventionally talking about. Now, in this case, it required to do a 24 millimeter of LR lateral rectus recession. When we are doing such large amounts, we may have to have a hemi hangback of about 7 millimeters, and we are going to stitch the muscle at 17 millimeters and let the lateral rectus hang for 7 millimeters. And in this case, the medial rectus plication of 8 millimeter was done, and you can see there is a improvement in the primary position and as well as the adduction, which has improved significantly. He is quite happy with this. Another case which I'd like to show is when the eyes do not cross the midline, if there are large deviations, and in that case, if the FDT is not very tight, then we can do a split LR transposition to the medial rectus, like in this case. And here you can see the tremendous improvement in the adduction, but you have to be very careful in splitting the lateral rectus in this procedure to at least 20 or maybe even 20 millimeters of the lateral rectus splitting should be there, or even more. Otherwise, there may be a pressure on the vortex veins and the ciliary vessels. This is another girl whom we had done, and this one also had a vertical deviations in the eye. So when we are going to correct the horizontal deviations by the right eye, we thought of doing the vertical deviations correction in the contralateral eye. And as you can see, she is now corrected by the superior rectus recession in addition to the split LR to MR, which was done in the right eye. So remember, you can always have the option of working on the other eye for correcting the other problems. If the FDT is very, very tight, then the lateral rectus split transpositioning the medial rectus is not recommended, and it is better to do some other options. Supramaximal recession is one thing which you can do, but otherwise you may do a periosteal anchoring of the lateral rectus. So in this, the lateral rectus periosteal anchoring was done, and in addition, the medial rectus resection was done 8 millimeters. In this case, this was done before we started doing plication, so the resection was done. Nowadays, I would probably do a plication instead of a MR resection, and you can see the considerable improvement in the third nerve palsy. Another case of third nerve palsy in which the FDT is very tight, and we need to do a supramaximal recession of the lateral rectus or the periosteal fixing, but still, since the exo is quite large, in such a case, one may have to do a periosteal anchoring of the globe to the medial periosteum. And this is what we have done and reported in cases. So earlier we were doing it through the DCR route, but nowadays we can do it through the retrocurricular or precurricular approach. Aberrant regenerations are another problem which can happen. This is like the joker in the cards, and we have to be careful about it. Now, when we have an aberrant regeneration, examine these eyes more carefully. And as you can see in this case, whenever the person is having an abduction, there is a ptosis of the right eye. But on attempted adduction and on looking down, there is a self-correction of the LPS because of the aberrant regeneration which is coming. The middle rectus innervation is now going to the LPS. Now, fortunately, in this individual, as you can see, the eyes are ortho in the primary position. So you need to just counsel this case and do not operate. But this another lady who has an exodeviation, we have to take advantage of the aberrant regeneration in this case and operate on the contralateral eye. Now you see the left eye was involved eye with the LPS having the involvement, and I have operated on the right eye with the supramaximal recession of the lateral rectus and the tightening of the middle rectus. This is known as a fixation duress surgery, and you can see the improvement not only in the deviations in the primary position, but also in the LPS action. This is another case in which the aberrant regeneration after the surgery has improved the ptosis. Sometimes we have acquired partial third-nerve palsies with only an inferior division being involved, like this girl who had a vascular angioma in the brain, which was operated by the neurosurgeon, and subsequently she had this inferior division problem. And so in this case, I plan to do an FDT of the lateral rectus and of the superior rectus. And I found them both to be free. So I modified inverse NAP.
1 minute remaining, sir.
Was what I planned, and this is we have done. In middle rectus, sometimes we can do a modified Nishida's technique, which will improve the adduction, like in this case, which was described. And then we have lateral incomitances in some cases, and recently we do a resection and recession on the same lateral rectus to improve the lateral incomitance. So this also corrects the, so just to summarize, the important points to remember are: look for the deviations in the primary position and other cases. Look for any incomitance. Realistic goals to be set and explained to the patient. Individualize the treatment. FDT for lateral rectus is very important, and supramaximal recessions may have to be done, even periosteal fixation of the lateral rectus, and if the FDT allows, a split lateral rectus to MR can be done. Contralateral muscle surgery is always an option, whether for a vertical deviation which is there or for the aberrant regenerations. So these are the points. We need to have a squintellectual approach and correct the third nerve palsy in a more holistic measure and spread the sight and stereopsis. Thank you all.
I think we, all of us have listened to the pearls given by Professor Pradeep Sharma sir. And any questions or any doubts, I think we can have towards the end, or people can put it in the chat box. And we can still take maybe around a question or so now, since we have time. In case the second speaker is ready, Dr. Murlidhar, who is going to demystify nystagmus for all of us, I think we can start with the second series and then take the questions towards the end.
Thank you, Dr. Anirudh, and I thank DOS for having invited me, and my acknowledgements to my mentors, Dr. Pradeep Sharma sir and Dr. Rohit. So I'll be talking on demystifying nystagmus. So nystagmus by definition is a regular rhythmic to and fro oscillatory movements of the eyeball, and usually it's involuntary. So you have to take a detailed history. Remember to ask for history of oscillopsia, as that is what primarily distinguishes acquired from a infantile nystagmus syndrome and associated clinical features. So the most important thing in nystagmus examination is, of course, the visual acuity and refraction, and whether it is manifest in primary position or only on cover or only on eye movement. I have modified this information from mrcoff.com, and I find this to be very useful. Right. So this patient, this child had a poor fixation, and that is his father. So the diagnosis is quite obvious that this patient has oculopicnous albinism. He also had foveal hypoplasia, and that is the reason for his sensory nystagmus. So this patient had poor visual acuity of around 6/60, was a neglected congenital cataract which has not been operated. So any opacity of the visual media in less than 2 years of age causes a sensory nystagmus. The right eye has been operated and the left eye was scheduled for surgery. Nevertheless, she developed nystagmus because the surgery was delayed. So this is, I mean, the classification into sensory and motor nystagmus is artificial. Nevertheless, remains a clinically useful classification. And in some patients, like this patient had a vision of 6/36. The fundus was normal and poor vision was there since the first year of life. There was a history of consanguinity and vision was quite poor, 6/36, despite the best corrected refraction. And this patient was diagnosed as having cone rod dystrophy because the patient has flat recordings on ERG. So this is another interesting.
Clinician should be able to pick up fine nystagmus as seen in this patient. And ERG shows a cone rod dystrophy.
So there could be 3 causes for an asymmetric nystagmus. If I may play the video again, notice that the left eye alone is shaking. And there are 3 causes. One is poor vision in the eye, second is cone rod dystrophy, and third is lesions of the optic chiasm. So these are important causes for asymmetric nystagmus. So this patient again was referred with poor vision. Notice that she has a latent or a fusion maldevelopment nystagmus. So in this patient, the key to one is that they may be referred for poor vision when monocular visual acuity is checked. This is a fusion maldevelopment nystagmus. The second is that to test vision accurately, record the binocular visual acuity, which should be done in all nystagmus patients. And also you can fog one eye or use Polaroid glasses to record visual acuity in the fellow eye. So now coming to infantile nystagmus syndrome, which is the most common thing that we as pediatric ophthalmologists handle. So you have to pay attention. They are characterized by a head posture and a null zone generally. Null zone may be in primary position. It is accentuated by fixation. The nystagmus is less for near, so it is damped by convergence, distinctive waveforms in ocular motility recording. It is horizontal irrespective of where the patient looks. There could be a torsional component in addition. Generally, it's symmetric and conjugate. This is what characterizes infantile nystagmus syndrome. So once you diagnose infantile nystagmus syndrome, the treatment other than optical correction and amblyopia therapy, which is the primary thing that you should do. Other than that, the surgery has 2 principles. After you have repeatedly confirmed the head posture on observation periods of at least 8 minutes on at least 2 occasions. That's what we do. After giving them the optical correction, treating amblyopia, we confirm the head posture on at least 2 occasions over observation periods of at least 8 minutes or more so that you don't miss out on pan. So the principle of surgery is to mechanically move the null zone to the primary position or to broaden the null zone. And generally I follow Sharma sir's technique of either using the augmented Anderson, but if the head posture is large, you can add application of the yoke muscles in addition to augmented Anderson. Note that when you correct the head posture, this patient has a large amplitude nystagmus. And I mean the final head posture can be made out by the reversal across the null zone. So this is post-operative. After surgery, the patient still has a small head posture, but is much more comfortable. The nystagmus amplitude is reduced in primary position. And this is yet another patient. This patient had a large head posture. So in addition to the augmented Anderson, we also added a plication augmentation. The head posture measurement is done by the goniometer. And you note that when you force the head posture correction after giving them a distance fixation target, note that for near fixation, hardly they have any head posture, but the surgery is tailored on the distance fixation target. So the near head posture is not worsened and the distant head posture is fully corrected. So this is yet another patient who had a large head posture and is fully corrected by the augmented Anderson procedure. For vertical head posture, for a vertical null, this patient has a chin up head posture. So when you correct the head posture, the nystagmus kicks in. So it is important. I usually operate them around 6 years of age. So it is important to tell when examining younger patient that the parents should not be forcibly correcting the head posture. So this is how we measure the head posture. Increase the prisms until you obtain a small reversal of the head posture. So that tells you that this is the maximum amount, and usually you augment it 10% over and above the dosage. And we did a so you shift the eyeballs in the direction of head posture. So this patient had a chin up head posture, which is seen in the inset here, and after surgery, she's fully corrected with vertical Kestenbaum procedure. So if you have a complex head posture, like this patient has a chin elevation in addition to a right face turn, try to correct the most prominent head posture first. I usually do it in stages because nystagmus surgery is very unforgiving. So this patient does have a small head posture, but the tilt and the chin elevation is gone now. So this is a difficult situation because this patient has an exotropia, has a latent nystagmus, and also has a face turn towards the fixing eye, has an adduction nerve. So this patient has a manifest latent nystagmus. So notice the large head posture. Whenever you cover one eye, the face turns towards the fixing eye. Very difficult to manage. So what we did was we used large recessions of the lateral rectus along with the Fadden on the medial rectus. So that seems to have addressed the exotropia and the head posture as well. And in case you have a combination of both strabismus and nystagmus, so then you operate on the fixing eye, on the dominant eye for nystagmus, and adjust strabismus in the other eye. So this patient had a right esotropia along with a face turn to the right. So what we did—
1 minute remaining, sir.
Yeah, and medial lateral rectus resection. So we got a good correction of the head posture. So nystagmus surgery can be very unforgiving. This patient had a stretch scar and esotropia, which was corrected. So notice the stretch scar here. We excised the stretch scar and got it back in position. So this is a very interesting patient. So patient came with history of oscillopsia. Note that the patient is able to start and stop the nystagmus at will. So this is a voluntary nystagmus, needs no further investigation. They will never be able to sustain it for more than 1 minute. This is a voluntary nystagmus. And this patient has a typical seesaw nystagmus. On confrontation fields, this patient also had a bitemporal hemianopia and had a large stellar mass. So seesaw nystagmus, if it is not congenital, if it is acquired, you have to immediately scan the patient. The location of the lesion is usually paracellular. So this is not exactly a emergent Parinaud's dorsal midbrain syndrome. So this patient had a midbrain glioma. And this is another very interesting patient. This patient came with very vague history and about the room tilting to one side. Notice this eye movement which was recorded on slit lamp. And this is a torsional, conjugate torsional eye movement. The patient never really complained about this. This is a typical torsional.
Apologies, sir, but the time is up. If you could sum it up in the next 30 seconds, please.
Yeah, sure. So this patient had a posterior inferior cerebellar artery infarction. This is my last slide. And this is a patient with Brunn's nystagmus. So notice that to the left side, this patient has a large amplitude nystagmus, and when to the right side, the frequency is more, but the amplitude is less. And so this patient had a disc edema, had a 7th nerve palsy, and was diagnosed to have a large hydrocephalus with a CP angle tumor. So I'll just exit here. I mean, I had a few more slides, but I think I will exit here.
I think we all do understand, nystagmus is a very vast topic, but beautifully covered by Dr. Muralidhar. And any doubts, I think, can be taken up in the chat session later on. And we'll move on to Dr. Pradeep Agarwal from the CL Gupta Eye Institute. Dr. Pradeep, I think your slides are ready. You can start off with the lateral rectus palsy options.
So, good evening, everyone. So, I think my slides are visible.
Yes, sir. Just put it in the presentation mode, sir.
Okay, just 1 minute.
Yeah, it's visible.
I think it's okay.
Yes, sir.
So, good evening, everyone. Today I am speaking about the lateral rectus palsy management option. So, general treatment depends on the etiology of the abducens nerve palsy. In general, underlying condition like the systemic condition like diabetes mellitus and the hypertension, you have to treat primarily. And most of the patients with the microvascular abducens nerve palsy are observed and usually recover within the 3 to 6 months. During that time, you have to provide non-surgical treatment in the form of the prisms, occlusion to avoid the diplopia, segmental occluting devices, or Botox injection in the medial rectus muscles. If you talk about the surgical management, then at least you have to wait and watch at least for the 6 months. Among the slides, so if you talk about the surgical management, most of the time in the case of the 6-nerve palsy, the esotropia is more than 30 to 35% diopter. If it is the less than the 20% diopter, then you can go for the medial rectus recession alone. But in the case of, if it is the esotropia is more, then definitely you have to test the lateral rectus muscles. But before touching the lateral rectus muscles, you should check for the abduction movement. If there is the adduction movement that is crossing the midline, then you should think about the resection or the plication. Otherwise, you have to dependent on the transposition rectus muscles. That can be in the form of the full tendon transfer, or it can be in the form of the partial tendon transfer, or it can be in the form of the isolated vertical rectus transfers. So let us discuss one by one. But before going for the transposition procedure, your aim should be clear. You have to correct the manifest deviation. You have to centralize or increase the field of the binocular single vision. And you have to overcome or reduce the need for the large compensatory head posture. If you talk about the full BRT, you have to transfer the insertion of the superior rectus and the inferior rectus towards the lateral rectus muscles. And this full BRT can be augmented by the cross-adjustable approach. By that, you have to transpose superior rectus and the inferior rectus below the lateral rectus muscles, and you have to attach at the respective opposite corner of the LR insertions. In this cross-adjustable approach, it increases the transposed muscle pathway by avoiding the resection of the transposed muscles. Another advantage is that it allows post-operative recession of the appropriate vertical recti muscle to correct any induced vertical deviation if post-operatively it is present. And it also allows reversal of horizontal overcorrection by recession of the transposed muscle from new point of insertions. If you talk about the partial BRT, then the Jensen procedure is the known choice. And in this case, you have to split the SR, inferior rectus, lateral rectus, and superior half of the LR, you have to tie it with the SR, and the inferior half of the lateral rectus, you have to tie it with the inferior rectus. And nowadays, a lot of the pediatric ophthalmologists prefer the Nishida procedure. In the Nishida procedure, you have to split the superior rectus muscles around 8 millimeter behind the superior rectus insertion, and you have to pass the 60 nylon suture, and you have to tie same suture in the superior-temporal quadrant around 8 millimeter behind the insertion of the lateral rectus muscles. Now, there is the little modification of the Nishida procedure in which you don't even go for the splitting of the superior rectus muscles. Just you have to pass the suture from the lateral half of the superior rectus, and you have to tie this suture in the superior-temporal quadrant around 10 millimeter behind the limbus. So, the advantage of the modified Nishida procedure, there is no split and there is no tenotomy. So most of the time, this is better for the anterior segment ischemia point of view. Nowadays, a lot of the things are going for the superior rectus transposition, especially in the case of the DRS. But now few pediatric ophthalmologists, they are doing for the lateral rectus palsy. In this, you have to transpose only the superior rectus insertion to the LR, and you don't need to touch the inferior rectus muscles. And there the significant improvement in the mean angle of the esotropia, abduction limitation, head turn, and with the recovery of the strabismus in 80% of the patients. If you talk about the complication of the BRT, then like the other skin surgery, there may be undercorrection, overcorrection, and new onset symptomatic induced vertical deviation, and the chances of the anterior segment ischemia. Vertical tropia are reported around 6 to 30% of the patient after BRT, and that can be minimized by the meticulous surgical dissection of the attachment. If you talk about the anterior segment ischemia after the BRT, then this is supposed to be one of the serious complications that can happen after BRT. and it occurs due to the transaction of the anterior ciliary artery. So if possible, try to do these surgery under the microscope and try to save the anterior ciliary artery. If you grade the anterior segment ischemia, then you can grade into the 4 grade, grade 1. Then there will be the reduced iris perfusion that cannot be seen clinically, but in the grade 2 and grade 3, there will be pupillary abnormality along with the uveitis. So most of the pediatric ophthalmologists post-operatively see the squint not on the slit line. So if you are doing the BRT surgery, I will advise to go for the slit lamp examination to rule out the uveitis too. In the grade 4, there may be the keratopathy. If you talk about the treatment for the anterior segment ischemia, in the mild cases, you can simply go for the topical steroid, and in most of the cases it resolves. But in the severe cases, you have to go for the oral steroids. But prevention is always the better. As I told earlier, try to preserve the anterior ciliary artery with the help of doing the squint surgery under the microscope. You can plan the staging surgical procedure at least after 4 to 6 months, and you can go for the onyx incision. And there is a lot of the advantage of the modified Nishida procedure. You can preserve the ciliary circulation. You can avoid the compromise any residual.
1 minute remaining, sir.
And it permits the simultaneous ipsilateral horizontal rectus. Thank you for the listening, everyone.
Dr. Anirudh?
I think this was beautifully covered by Dr. Pradeep Agarwal in the limited time available. I'm just tempted to ask, the experience of modified Nishida. I think Professor Pradeep Sharma has done a lot of cases on that, what I remember. So, sir, if you can just throw light, we still have maybe around 30 seconds more before we call the next speaker, sir.
Yeah. So the modified Nishida is a very useful addition to our armamentarium now, because as Dr. Pradeep has already highlighted, that there is no tendon splitting and there is no disinsertion. So it does have a better control on the anterior segment ischemia, but still there is a possibility of anterior segment ischemia even in modified Nishidas. Because of the stretch, the vessels sometimes can be kinked, and it can be. So you have to be careful. And as he mentioned very correctly, that whenever you do any vertical rectus transpositioning, including Nishidas, you should have a slit lamp examination on the next morning. That is one thing. Secondly, when we are doing the modified Nishida, the effect depends upon where you are fixing the vertical rectus sutures. If you are placing it between the superior rectus and the lateral rectus, as described by Nishida, the effect is there, but not as much as if you can vectorize it still closer to the superior border of the lateral rectus, as I prefer to do in cases, and I find it is very, very effective. It is definitely much more effective than the SRTs that people talk about. So that is one thing, because you need to transpose the force where you want it to be there. So this is very important. Some people sometimes talk about Jensen's procedure. I would just like to say that Jensen's procedure should not be done, because you are transferring the force of the good vertical recti through a paralyzed muscle. It is like having a bad courier system to send your letter to the people whom you are concerned about. It will never reach there. So it is better to direct bank transfer. It should be directly stitched to the sclera like modified Nishidas. So Jensen's procedure is having a big drawback. It may appear similar to Nishida's, but I think Nishida is more effective because you are having a direct transfer to the sclera, and it is very effective.
Sir, thank you, sir. If we have the next speaker, Dr. Sunita Agarkar, who's going to speak on superior oblique palsy. I think we can start with her lecture, but I don't see her in the panel here. If Dr. Sunita is not ready at the moment, next is Dr. Suma Ganesh. Ma'am, I think she's there. Ma'am, you can start with your lecture on the DVD dilemma.
I'm really sorry to interrupt, sir, but I think Dr. Sumita's video is there with us. Rupesh from the AV team?
Sir, yes, sir, replay.
Correct, no? We have the video, right? So just the only question that I have for the chairpersons and the moderator is, the video is 16 minutes and the time allotted is 8. So whatever you say we will play the video and rest is up to you, sir.
Yeah, I think
Is that okay, or would you like to take it at the end, sir? Whatever your call. Dr. Pradeep sir, आप कुछ बोलना चाहते हैं?
is Dr. Sumita there?
अभी तो थी, but अभी गायब हो गई है.
Let's have Suma's presentation then. Let her be there at least, in then we can probably run her video as per her desire. She may then fast forward or do whatever.
Sure, sir.
Let's have Suma.
ठीक है, Dr. Suma, if you could start your screen sharing then. Thank you.
Thank you, sir. At the onset, I would like to thank the DOST committee, scientific committee, and also my chairperson, Dr. Pradeep Sharma, for giving me this opportunity. I would be speaking on dissociated vertical deviation. In dissociated vertical deviation, we know it's one of the most challenging situations we face in strabismus because it is never ever fully treated. In this, we find that there is a tendency to elevate, abduct, and extort when the binocularity is suspended by occlusion or spontaneously when fatigued. So we know that it is a marker of early disruption of normal binocular function. So we do find it in most cases, or whenever there has been some disturbance in the disruption of the normal binocular function. So it may be manifest or latent. The characteristics are most of the time it is it's almost always bilateral. It does not follow any Hering's law. It is associated with anomalous head posture like commonly a head tilt and associated frequently with nystagmus. So how do we measure it? How we measure it? With a translucent occluder may be used to disrupt the fusion and observe the DVD under cover. Base down prisms and cover are placed in front of the dissociated eye. As the cover is switched to the fixing eye, only note the movement of the DVD eye. Point of neutralization is no downward movement of the eye. So we measure it as it could be a small DVD, 0 to 9 prisms, moderate, or a large DVD. The indications are increasing frequency of manifest DVD, patients with an anomalous head posture, and a DVD that is large and occurring infrequently. So the surgical management dilemmas are, do we need to operate? Like this is a latent DVD and here there is a manifest DVD. So we normally go operate when there's a manifest DVD. If it's a latent dissociated vertical deviation, we leave it alone. We give them the best possible refractive correction. So for a comitant DVD, the most common surgical strategy is superior rectus recession. Whether we go in for unilateral or bilateral, we do a Farden is what we will be discussing. So in this patient where there is what we find there is the orthoptic measurement shows a exotropia of 15 prism diopters with a manifesting DVD of 15 prism diopters, and it is equal in both the gazes. So this is a unilateral DVD, a comitant DVD. So the issue is whether I should go in for a unilateral or a bilateral superior rectus recession. Several authors have advocated bilateral superior rectus recession for all patients with DVD unless a dense amblyopia is present in the non-fixating eye. In this patient, I did it a unilateral as it was a dense amblyopic in the non-fixating eye. But what we find that in most of the cases that there will be a change of fixation preference after unilateral surgery, and again there will be a DVD again being present in the contralateral eye, which was not. It was latent before, and it may again develop a significant DVD in the other eye. So it is important that we do a bilateral superior rectus recession. So symmetrical or asymmetrical. So here you find that there is a right exotropia with a DVD in both eyes. Now what do you mean by asymmetry? In the right eye, there's a DVD of around 14 prisms, and in the left eye, 6 prism diopters. And so this is asymmetric DVD. So should we do superior rectus recession the same amount, or should we do a larger in the other eye which has a more DVD, and a smaller superior rectus recession in the other eye? So this is what we practice, is that we do a asymmetric superior rectus recession in both eyes. And this is the result. Now we studied in our patients where we did a retrospective study of our own patients who had undergone, and this was published in the Asia Pacific Journal of in 2019, where we saw our patients who we had underdone bilateral superior rectus recession for bilateral comitant DVD, and we followed them up, and we found that the follow-up was minimal to 12 months, and we found that the mean preoperative DVD measure
We believe we've lost connectivity with Dr. Suma. Dr. Anirudh, if we could have the next speaker then. We've got Dr. Subhash Dadeya, sir. Can I request Dr. Subhash, sir, to please share?
I'd like to invite Professor Subhash Dadeya, sir, and in fact compliment for a beautifully organized DOS meeting also at the same time, sir. Over to you, sir, for management of monocular elevation deficit, sir.
Dr. Anirudh, there is until and unless Dr. Suma's slide, I cannot share.
Suma is joined back. Is she there?
Okay.
Can she complete?
I think Dr. Suma is also back. We can just finish off
So
with
I
her
cannot
remaining
share
presentation.
the screen until.
Yeah.
Okay. Right. Dr. Suma, ma'am, I think you can finish the remaining part.
And there's something wrong with my internet connection today. I don't know it's not moving forward. I think maybe I'll just stop here because it's not moving forward also. There's something wrong with the internet connection today. Dr. Subhash, maybe you could go ahead. I'm so sorry.
In that case, I think we'll start with the Dr. Dadeya, sir.
No, it's come again. Okay, now sorry, I'm so sorry. It's moving now. So inferior oblique anterior transposition is the surgery which is the choice whenever we do DVD with an associated inferior oblique overaction. And so in this procedure where we place the inferior oblique next to the inferior rectus, so asymmetric inferior oblique anterior transposition for concomitant DVD has also been recommended. So you could place one which is at 0 station and the other at -1. So you can do an asymmetric inferior oblique anterior transposition too. So the other triad is where there is associated the DVD which is present more in abduction. And this is associated with superior oblique overaction. So this is a triad where there is a DVD, there is a superior oblique overaction and an A pattern. And we studied this, so you can see this where you can see the DVD maximum in abduction. This is because of the superior oblique overaction of the other eye and the contralateral eye. And this is what we see. And we published in the Oman Journal of our case series, in the Oman Journal of Ophthalmology, where we did simultaneous surgical correction of DVD, superior oblique overaction, and the A pattern with associated horizontal strabismus, like a 6-muscle surgery, where we did both eye lateral rectus recession, superior rectus recession, and bilateral PTSO. We found good results, but and we did not find the PTSO causing any changes in the horizontal deviations. So our A pattern decreased from 26.25 to 6. And we also had a collapse in the A pattern. DVD in the primary position also decreased, and DVD asymmetry also decreased when we did this triple surgery of all the muscles. In CVI, we find that commonly that is seen, and what we find that with the superior rectus recession, like this child had a DVD with an A pattern. So bilateral, so we looked up literature to see whether the superior rectus itself will collapse the A pattern, and we found that in this case, it did collapse, the superior rectus recession did collapse the A pattern, which was seen in the case of DVD. And this was another case of CVI who had a DVD, and there was even residual DVD even after doing a right eye lateral rectus recession and a superior rectus, asymmetric superior rectus recession. We found that still there was a DVD in the right eye. So for the residual DVD, looking up literature, we did a right eye plication of 4 millimeter. So it give a very good effect, but we found that there was some limitation of elevation in the first 1 month after the surgery, which resolved after some time. So these are the different options of DVD, and this is the surgical correction protocol. Any questions? Because DVD, I find, is the most challenging form of strabismus. Any questions? Thank you. I'm so sorry, and thank you for adjusting me.
It was a wonderful lecture on DVD, ma'am. Any questions?
I wanted to ask Dr. Pradeep Sharma, sir, and Dr. Subhash, do you also check that, see that in the inferior rectus plication after the, do we get a small amount like a tuck effect, or did I do something wrong?
Ma'am, actually, inferior rectus plication is the primary choice now in cases in which inferior oblique overaction is not there. So in what I have seen, IR plication is much more controlled procedure than doing a superior rectus recession. So if there is an inferior oblique overaction, of course, you will do an IOAT. That is,
yeah, IOAT, okay.
If there is no inferior oblique overaction, I would do a inferior rectus plication because it is not anti-segment ischemia risk. So, and when you're saying that anti-elevation effect is coming, that is what we desire. So IOAT is also preferred for the same reason that you have an anti-elevation effect. So little anti-elevation effect is the desirable thing in DVDs. So that's why with a lesser amount of judgment, we did the thesis in RP Center before I retired, and we found that we had much more effect with the per millimeter with the IR plication compared to the superior rectus recession.
Okay, thank you. Thank you.
Ma'am, may I ask a question? This is Siddharth from Lucknow.
Yeah, sure.
Sir, ma'am, do you have any experience with down displacing the horizontal recti in moderate DVD when we are dealing with a horizontal deviation? Like a surgery is planned for an exotropia, and this child also has a moderate amount of DVD. So along with the RNR procedure, down displace the horizontal recti, and I've seen it takes care of a moderate amount of DVD in one of the eyes. If it's an asymmetric.
I think for a hypertropia, yes. Like if there's an associated hypertropia, we do the downward displacement of the horizontal muscles. But also for the DVD, you have seen.
For hypertropia, it's like done routinely. But specifically for DVD, I've done it in a few patients with quite gratifying results. So, I
have not done it for downward displacement of the DVD. What I feel is that just correcting the horizontal muscle, sometimes horizontal deviation, sometimes take care of a small amount of DVD. So you know that itself improves the DVD if there is a small amount of DVD. So I have not done the downward shift. So maybe we could try it next. I don't know. Dr. Sir can say, Dr. Pradeep Sharma can say.
I just wanted to apologize, but ma'am, we are running short of time. If we could.
Okay, fine.
Thank you. I'm really sorry, ma'am.
No, it's okay. Fine.
Yeah, we will start with Dr. Dadea sir with his presentation on management of monocular elevation deficit. Over to Dadea sir.
Dr. Subhash sir, if you could please switch on your camera, sir. Sorry. Yeah, sorry, I was trying to switch it on, sir. Yes, sir, we can see you, we can hear you.
You can hear me, but my slides. Slides are visible?
Yes, sir.
So, sorry for some technical errors. And thank you, chairpersons and dear friends. I will be speaking on diagnosis and management of monocular elevation deficit. Basically, it is inability to elevate paretic eye from any position of gaze, provided ductions are normal in all other positions of gaze. It may be due to paresis of superior rectus and inferior oblique with ptosis, or it may be due to superior rectus palsy of long strain. Initially, the term was DEP, which was coined by Dunlop. It may be congenital or acquired. It may be paretic or restrictive or supranuclear. Nowadays, MED is more commonly used because it is more accurate term, as paralysis of both muscles independently and supranuclear lesions can lead to impaired unilateral aqueous pulse. Various causes could be congenital, supranuclear defects, SR paresis, IR restriction, neonatal hypoxia. In acquired, there may be serious diseases, midbrain tumors, acoustic neuromas, sarcoidosis, and in our setting, the cysticercosis is also a common cause of acquired MED. This is ultrasonic picture of the patient in which you can see the cyst. Various types of MED are type 1, that is due to inferior rectus restriction. Type 2 is due to prominently weakness of the elevators, and type 3 is combined type. Clinically, there will be limitation of elevation above midline, both in abduction and adduction. There will be hypotropia of the involved eye. There will be ptosis and pseudodosis. These are the clinical photographs of the patient with MED. Usually there is elevation of chin. Usually it is unilateral. Marcus Ganza winking phenomena is seen in 25% of the patients. These are the photographs of another patient. It is important to ask history of onset. If sequence of events is not clear, then presence of amblyopia suggests congenital etiology. You must look for previous photographs, and in acquired cases, there will be history of neurological symptoms, past medical history, or general systemic symptoms. In type 1 MED or DEP, FDT will be positive. In type 2, FDT will be negative. There will be reduced saccade velocities. Acquired DEPs, these patients, they present with sudden onset of acquired diplopia in upgaze and with neurological symptoms. Ptosis is usually not present, may be associated with pupillary anomalies and convergence weakness. This phenomena is usually present, and patient often assumes chin-up position. This is a clinical picture, photograph of a 20-year-old female with post-traumatic MED, and FDT was suggestive of tight IR. This 35-year-old male with right acquired MED is case of sarcoidosis with high age level and hilar lymphadenopathy in the CT chest. This is 20-year-old female resident of Delhi presented to the OPD with chief complaint of diplopia with 1 month and was detected to be the patient had cysticercosis, and you can see the ultrasound. In the ultrasound, you can see the cystic lesion in the inferior rectus muscle. And after managing this patient with albendazole and steroids, patient was orthophoric and elevation limitation was also got resolved. So it is very important to differentiate congenital and acquired MED. Congenital is usually in children. Acquired can be in any age. In congenital, onset is at birth. In acquired, it can start at any age, and acute onset diplopia in primary gaze and up gaze is the prominent feature in acquired MED. Usually, acquired is associated with the systemic associations, and in congenital, amblyopia is more common, and in acquired, diplopia is more common. Differential diagnosis could be Brown syndrome, vertical twins, congenital fibrosis of inferior rectus, congenital absence of superior rectus and inferior oblique, abnormal insertion of inferior rectus and superior divisional third nerve palsy. Differential diagnosis of acquired DEP would be thyroid orbitopathy, myasthenia gravis, orbital floor fracture, third nerve palsy, orbital cellulitis, orbital inflammatory disease, previous cataract surgery, and cerebral tumor. This was patient of this patient presented like MED, but was found to be a case of ocular myasthenia. Then, what are the indications for surgery? Significant abnormal head posture in primary position, significant vertical deviation in primary position, contracted binocular fields, diplopia in primary gaze. In most of the patients, we have to observe, because with limited head changes, the patient can maintain orthophoria. However, treatment for MED or DEP is surgical and only surgical. Goals of the surgery are to achieve cosmetically acceptable deviation in primary position, to increase the field of binocular single vision, and it is important the surgery will not cure MED, and more than one surgery is required in this sort of the patients. And usually these sort of patients, they come with the ptosis and they want to get ptosis corrected. So we have to explain in very clear terms that first the squint surgery has to be done and then the ptosis surgery has to be done at a later stage. Optimal surgical treatment for DEP remains controversial. However, treatment of DEP should be according to the type of DEP, and type 1 MED, recession of the involved inferior rectus is the treatment of choice. In type 2 MED, NEPS procedure is well established and commonly practiced procedure. However, drawback of the NEPS includes some, if patient loses some abduction and adduction, effectivity decreases if the deviation is more than 25 prism diopters. These are photographs of the NEPS procedure. Then azotenectomy and vertical muscle recessions have been found to be effective in congenital DEP by a Chinese study. Then Sneer et al. Recommends NEPS procedure with posterior fixation sutures, and DEP with horizontal deviation can be taken care by modified NEPS procedure. These are the clinical photographs and post-op photographs of the MED. This is pre-op. This is day 1 post-op photograph. This is pre-op photograph of another patient, and this is the post-op photograph after after squint surgery and ptosis correction. When to intervene for ptosis? Minimum of 6 months after squint surgery, because magnitude for vertical correction increases with time following NEPS procedure. Thank you very much.
Thank you, sir. I think you finished right in time, and the diagnosis of acquired MED definitely remains a very difficult thing. And so do you follow a certain protocol while managing cases where you do ultrasound for all cases? Because cysticercosis remains a very important cause in our scenario.
So basically, as I told, if the patient has diplopia in up gaze, that is one clue that the patient is case of acquired neurological symptoms, cardiological symptoms, or systemic symptoms. If they are there, then that points towards the acquired MED.
Sure. So I think the next speaker is also here, Dr. Shailesh, and he's going to speak on the Duane retraction syndrome, its shoots, retractions, and limitations.
Sir, I have to leave, so.
Sir.
Okay.
Sir,
Thank you, sir.
Okay, Dr.
Sir,
Thank you.
Over to Dr. Shailesh for his presentation.
Yeah, good evening, everyone. Good evening to our chairperson and all the esteemed panelists. At the outset, I would like to thank our wonderful DOS organizing committee headed by Dr. Subhash Lade and Dr. Mamata Sharma and Dr. Rohit sir. And also it is a privilege to be part of this wonderful session, which is also being led by our mentor, Dr. Pradeep Sharma sir. So this is I hope this is the last talk. So I might overshoot because I deal with these overshoots and undershoots.
No, Dr. Sita is still there.
Still there. So okay, I will try to shoot less, sir, then. So it's on Duane retraction syndrome, on shoots, retractions, and limitations. So in DRS is one of the most common type of special strabismus that is of restrictive nature, and it is having 1 to 4% in all strabismus patients, commonly in women and more common in the left type. It is basically a co-contraction syndrome. It's a part of now congenital cranial disinnervation disorder. And here we have this congenital miswiring of the medial and lateral recti, where the third nerve come into picture, and the abducent nerve nucleus is usually absent or is quite weak. And here comes the problem. So it is a musculofacial innervation anomaly with fibrosis of LR and MR, fibrous bands, and a co-contraction which gives paradoxical innervation. There are 3 types, mainly 1, 2, and 3. This helps in planning for our surgical intervention, where the differential 6th nerve and 3rd nerve innervation is there. Now the classical features are marked limitation of abduction, slight limitation of adduction, and on adduction, there is 3 things that we notice, that is retraction of globe, narrowing of palpebral fissure, and upshoot or downshoot of the eye. We should not forget the other associated abnormalities in systemically as well as in the eye itself, like ptosis, cataracts, and nystagmus and all. Along with that, we have Klippel-Feil syndrome, golden heart syndrome, which is auriculovertebral dysplasia, and Wilder-Wang syndrome. So we should also look for all these things when we see a case of suspected Duane syndrome. So Huber classified into 3 types. First one is the type 1 is the commonest one with limited abduction, where there is no less of abduction movement, and there is retraction on adduction and the palpebral fissure narrowing on adduction. This is by far the commonest and this is another case with limited narrowing as well as limited abduction. The type 2 is least common, where a limitation of adduction is there, and on adduction there is globe retraction, fissure narrowing. In type 3, we have on adduction, there are all three things are happening. So this is the type 2 where there is limitation of adduction, whereas the abduction is okay. Now this is type 3 where there is both adduction as well as abduction. Abduction is weak, and of course they all have some face turn or head position to bring in the binocularity. Now, how do you manage these DRS syndromes? So its indications for surgery is mainly squint in primary position, abnormal head posture. They have severe upshoot and downshoots to be corrected, and cosmetic, that is narrow palpable fissure. So simple ESO-DRS we have, if we have small angle less than 15 to 20 prism, we do single MR recession. And if it is a large angle, we do bilateral MR recession. And if it is EXO-DRS, small angle, we do only single LR recession, or if it's a larger angle, we can do bilateral LR recession or supramaximal LR recession. One more important aspect is dealing with these upshoots, downshoots, and globe retraction. We have different approaches for them, like we can recess MR and LR, or we can do Y split of lateral rectus, or we can do posterior fixation suture to LR, or we have the larger subperiosteal fixation also. So here is one case where we have DRS type 1, where there's abduction limitation and a significant upshoot. And this was dealt with by doing, it's EXO-DRS basically. See, we also classify DRS on EXO-DRS, ESO, and ortho-DRS. It's a more practical approach. So here I did a Y split of lateral rectus muscle. So this is having a significant upshoot, and a conjunctival limbal-based approach was done. And after dissecting the conjunctiva, the muscle is hooked. We have to dissect the lateral rectus slightly far behind, so that we need a very large angle of, large length of lateral rectus to be dissected. So after hooking the muscle and then passing the sutures with 60 Vicryl to the insertion site, sorry that the view is slightly not in the center. Then you just have to make a nick in the middle, avoid the vessels, and hook the muscle into and split it into two halves. So once we have this muscle into two halves, and then you pass another additional sutures here. And now how long we have to split is that usually we split up to above 15 millimeters, and then separate them and keep it at a distance of about 20 millimeters away. That is called the Y split to have a best results. So after doing this, you pass additional suture on for each half of the lateral recti split muscles. And then after that, we can suture it and mark that recession part that we need to do it about 6 or 8 mm, and then separate the two halves on the upper part and the lower part and pass the suture. See, the upper part of the split muscle is being sutured to the sclera. So then the same thing is done on the lower part. So now at the end, we have these two limbs of the Y part that is separated by around 20 millimeters from the insertion. There is a recessed as well as Y split. So this helps in preventing the upshoot. See, this is a pre-op photograph of the patient with a very significant upshoot. And then there is also an EXO-DRS. Now it has become almost ortho-DRS, and the upshoot has come down from the above situation pre-op. It has given a wonderful result here. Another case is that it's a type 3 DRS. We have this slight restriction of adduction, and then there's significant upshoot in the right eye. And then this was tackled with maximum recession of the lateral recti because of this EXO nature as well as the upshoots. So, and medial rectus was also recessed by about 6 millimeter, and this gave a very good result of about ortho position, as well as you can see that there is upshoot is also come down. Here you can see the upshoot from here, and then here it has reduced. This is another case where we had a upshoot in the left eye, and the pre-op photographs and the similar Y split was done. In this case, upshoot, although it is slightly there, but it has reduced to a significant level and looks more of cosmetically better. The EXO is reduced as well as the upshoot is also reduced. This is a wonderful article written by my mentor, Dr. Pradeep Sharma sir. One should not miss it. It is in IGO, which really summarizes all the aspects of Duane syndrome. So based on that only, we can really have a very good clinical approach to this. In Duane's retraction syndrome, the management part is to have a very careful workup. Just look for any systemic anomalies, do a proper FTT to assess how good or bad is a lateral rectus innervation. Based on that, lot of decisions has to be made.
1 minute remaining.
Yes, sir. This is the last slide. And indications for surgery is, sir, many times DRS need not be operated if the primary position is okay and there's a mild co-contraction. So if there is any significant squint in primary position, if there is significant head posture, then we need to operate, or if there is any significant up or down shoot, or there is a palpable fissure changes, which looks slightly ugly for the patient to look at, needs to be operated. And the options are many, and that can be classified as exo, ortho, or ESO DRS. And depending on the FTT nature of the lateral rectus, we can go in for recession for horizontal squint, unilateral, bilateral, or periosteal fixation of lateral rectus, which is also done by at RP center, and they found one good results, along with Y-split for up or down shoots. Vertical rectal transposition can be done a partial thickness or a full thickness transposition, depending on the lateral rectus status. And in a severe retractions, large recessions, or in case of ESO-EXO DRS, we need a differential recession of muscles. Thank you.
Yeah. Thank you, Dr. Shailesh. I think you finished well in time. Nikhil, in case the presentation for Dr. Sunita is there, I think by the time you start with that, we can have a discussion on DRS. Dr. Shailesh, I'd just like to ask you, any strategy you follow for ortho DRS?
Yeah, ortho, yeah, good question. Many times ortho DRS, we just try to see, we will be more defensive, because you see if there is any significant co-contraction, or the globe is slightly more shrunken, or the palpable fissure changes are there or not, and the patient does not have any head position or abnormal head posture, we leave it like that. If there is any of these cosmetic appearances, co-contractions, palpable fissure changes, then we may tend to relax those contracting muscles.
Yeah. So, Professor Pradeep Sharma, sir, by the time I think the next presentation of Dr. Sunita is going to be played, so we can have your pulse on DRS.
I think as he's nicely presented, and he mentioned about that article in IGO, which we have tried to classify the DRS. Practically, it's important to separate them as ESO DRS, EXO DRS, and ortho DRS for the management purpose. And then further, we will subclassify them on the basis of the FDT being positive for the medial rectus. In case of ESO DRS, if the FDT is positive, we definitely have to recess the medial rectus. But mind you, we need to do the minimal amount of medial rectus recession. If you do a little more medial rectus recession, you need to counterbalance this with lateral rectus recession with Y-split. And usually, whenever there is a moderate to severe co-contraction, you would have to always do medial rectus recession along with the lateral rectus recession in an equitable manner. Otherwise, you may have an iatrogenically induced synergistic divergence.
One small question. Where do you do vertical rectal transposition, like partial versus
on the
small?
DRS cases, then you have to do for severe co-contraction, both MR and the LR, then you are at a risk of doing a VRT for in addition, because that would be the third muscle. So it is better to avoid an SRT or a PVRT. If at all, we have nowadays been doing, in some cases, a modified Nishida, to improve the abduction. That may be done, but you have to be careful. So vertical rectus transposition can only be done after you have taken care that the lateral rectus paradoxic innervation has been tackled. If it is a very mild upshoot and downshoot, that means the lateral rectus paradoxic innervation is not much. Then in those cases, medial rectus recession for its tightness and an SRT has been advised by Hunter group, Boston group. So as I said, if the co-contractions are not much severe, then you can do a medial rectus recession and a SRT or a PVRT or whatever your choice is that is there. Okay. For EXO DRS, you depend upon this fact that if the EXO DRS cases are usually having normal abduction or maybe no abduction. If they have a normal abduction, then you do not want to do a periosteal fixation. You should always do a procedure which is like lateral rectus Y-split recession under control. So you do not lose the abduction altogether, which is normal, but you want to reduce the co-contraction part by doing a lateral rectus recession with Y-split. But if there is no abduction at all, in those cases, severe cases of EXO DRS, one can do a periosteal fixation of the lateral rectus and also do a VRT to improve the abduction.
Thank you, sir.
Nikhil, is Dr.
Dr.
Meera's,
Sumita video. I just got a message from, I talked to Dr. Sumita. She's traveling, it seems. So she says that you can play her video and leave the video in that. There is a video of the surgery, which is itself for 4 minutes, that can be left. So it may reduce down. So you can play it for maybe whatever time, 8 or 10 minutes that we have. And in the meantime, if you have any questions, Anirudh, do you have any questions coming from people? Then you can ask the
I'll just see the chat box in case I think.
Chat box.
Okay.
If there are any questions.
Good evening. I would like to express my thanks to Dr. Rohit Saxena for inviting me to be part of this prestigious webinar. I'm also thankful to him for allowing me to present this with a recorded version. I'm talking on superior oblique, which is a very special muscle because it has a unique anatomy like no other extraocular muscle. It has its own cranial nerve. It has a primary, secondary and tertiary actions which may be troublesome for the strabismus surgeon when it gets palsied, and it can be affected by a variety of insults starting from tumor or ischemia or space occupying lesions or sometimes even a congenital abscess seen in children. Broadly speaking, you can divide it into a congenital superior oblique palsy and an acquired palsy. Congenital palsy is mostly present with dramatic abnormal head posture, which is basically a head tilt away from the affected side. You may be able to examine hypertrophy of the affected eye. And if these children present a little later, you can also have large vertical fusional amplitudes, which you can demonstrate in these children. And if we do a FDT on these children, often there is a very lax superior oblique. Like this child who presented to us with a head posture and would not allow head to be straightened. Acquired palsies are far more subtle, often present with diplopia, which is worse in down gaze. Head tilts may be present but very subtle. There is hypertrophy of the affected eye, which worsens in the opposite gaze and on the head tilt on the affected side. Again, torsion is a common complaint, which is often again worse in down gaze, as this lady you can see here, post meningioma surgery, has had a right superior oblique palsy, which you can see underacting superior oblique and overacting inferior oblique, and hypertrophy in the primary gaze, which is very small, not really seen in this picture. Important to differentiate acquired palsy from a decompensated congenital paresis, which also may present with diplopia. However, torsion is not a very dramatic feature in a decompensated congenitis. In bilateral palsies, you mostly see not a tilt but a chin depression. Important to note that they may be orthophoric in the primary gaze. There is alternating hypertropia inside gazes and on tilts. Torsion is significant, certainly more than 10 degrees. Any esotropia in down gaze is often present and it's almost pathognomic of bilateral palsies. Sometimes bilateral palsies in children can be masked and asymmetrical and often get diagnosed only after surgery for the palsy. So this is a gentleman here who has presented to us with diplopia, and as you can see, he has no orthophoria in the primary gaze, but has in the right gaze left hypertropia and right hypertropia in the left gaze, and same for the tilts. Diagnosis of the superior oblique palsy is mostly clinical. Sometimes you may have to do what we call as family album tomography, or basically looking at the old pictures to establish the diagnosis. If it is indeed an acquired palsy, then it requires a battery of tests, especially in acquired cases, to fix the etiology. And this may include imaging, blood work to rule out ischemic causes, sometimes physical examination, and even special imaging. Clinically, the Parkes three-step test is almost diagnostic if it is isolated superior oblique palsy, especially of recent onset. As you can see, this gentleman has a right superior oblique palsy. You can see right hypertropia more in the left gaze here and on the right head tilt. But must remember that as the comitance develops, Parkes three-step test may not be always positive in acquired cases. Sometimes torsion is also an indicator. As you can see here, extorsion of the fundus. You can also give an idea about objective torsion, and it is sometimes easy to see torsion this way in children than to go for subjective testing with the Maddox rod test. Now the tricky management. Non-surgical management includes appropriate glasses and occlusion, especially in children, wherever indicated. Also remember to give occlusion even in adults to relieve diplopia, especially in ischemic cases where palsy is likely to improve. Prisms can be prescribed for small angle vertical strabismus. However, it's important to note that prisms don't work very well if torsion is a significant part of the complaints. Patients with torsion are often not very happy with. Now, surgery is, most of the congenital palsies will require surgery, and we are immensely thankful to this gentleman here, Dr. Philip Knapp, for giving us a plan, surgical plan, which can be very confusing for beginners, but it is an important step, and it is a very helpful plan for most of the times for an advanced strabismologist. Clinic, what are your decision-making points to decide on the surgical plan? You look at angles in the primary gaze and also what is happening in the down gaze. You also look at postduction test for both superior rectus as well as exaggerated tendon traction tendon test for superior oblique and inferior rectus if required. You look and measure torsion, and not only in primary gaze but also in down gaze. And each of this must be addressed in your surgical plan for an optimum outcome in a patient. So what are the algorithms of surgery? Usually, in my experience and for skilled strabismologists here, a primary angle deviation of up to 15 to 20 prism diopters usually requires surgery on only one muscle. Now, how to choose this one muscle? If inferior oblique is overacting, weaken inferior oblique. But if your angles are more in down gaze, you need a muscle which acts in the down gaze. So you can either do a superior oblique tuck if it is very lax, or you can even choose a contralateral inferior rectus recession to take care of up to 15 PD of vertical tropia. Sometimes in long-standing superior oblique palsies, superior rectus has contracted and is often tight, and that also can be chosen as the muscle as a procedure of choice if your angles are more in up gaze or if the muscle is very tight. Again, if superior oblique is lax, tuck is the first choice, and this often helps in correcting the abnormal head posture in children more than inferior oblique weakening. Angles which are more than 20 usually require surgery on two muscles, and usually the first muscle is by default an inferior oblique procedure, weakening procedure, and it can be combined with a second muscle. Again, which second muscle to choose? You can use the same parameters as I mentioned earlier to select the second muscle. If torsion is a significant factor, as in bilateral palsies, you may look at a surgical plan which also includes especially surgical procedures which address the torsion, like bilateral superior oblique tuck or a Harada-Ito procedure, medial rectus recession with downshift, or sometimes nasal transposition of inferior rectus, usually done bilaterally. It may have to be combined with surgery, which you are planning for vertical strabismus.
I think, Nikhil, you can stop here. So
Okay, sir. No problem, sir.
So, over to,
Dr. Anirudh?
Any questions, Anirudh? So,
Sir, there was one question from Dr. Reena about the extent of supramaximal recession in fixation duress surgery, sir.
yeah, so this would depend upon the deviation that the eye is having, one. And secondly, more than that, we need to have a fixation duress. So you would have to do a large amount of LR recession because we are operating on the normal eye. The large would mean that it may be around 12 millimeters. So anything between 10 to 12 millimeters of LR recession would be done. And the medial rectus again would have to be tightened in order to give a fixation duress, because you want the innervation effect to come in the ipsilateral medial rectus innervation, which is now going to the LPS. So you would have to do it. So there was one nice study with Dr. Shweta Chaurasia. So at that time she had tried to do, and I think that may have got published also, that on the basis of the amount of excursion that we make and how much is the lid lifting, you can plan how much of fixation duress surgery you can do. So as we are seeing the eye, the contralateral eye movement, and as it abducts and you see the lifting up of the lid, so that much is the amount of the movement that you want to create. So you'd have to do a correction for that deviation.
Sir.
Is it clear?
Sir. Nikhil, do we have time in this session, or?
I think we have time because it's up to you. So if there are any,
We have approximately 14 more minutes.
Okay.
And since this is the last session, a little bit exceeding would not be a problem.
Okay, didn't tell us earlier.
Yeah, in fact, I had a question for Professor Pradeep Sharma, sir. Sir, regarding the acquired torticollis, sir,
Nikhil, can we have all the panelists' videos on so that everybody is on the board?
Yes, we just need the videos on, only then we can spotlight them. Yes.
So
okay.
So you can have the gallery view of all people, so that
yes,
are also involved, and we can. Yeah. You don't spotlight. I mean, you can have all the people there.
Sure, sir.
Yeah. So sorry, Anirudh, carry on.
So basically, I just wanted to ask about the differential diagnosis for acquired torticollis, so that we don't jump the gun and go in for an ocular torticollis and rule out the other causes, because sometimes cases can be a little tricky. Acquired torticollis.
Acquired torticollis in respect to the superoblique palsy or nystagmus? Your question is?
In respect to superoblique palsy.
In superoblique palsy, okay. So if you have a acquired torticollis, what is your question? That we should
basically that we rule out some kind of a, if it is an acquired case, so we don't immediately jump that there is a history of a road traffic accident and there is actually a superoblique palsy, because sometimes congenital pieces, there may be a case where a child has a skeletal muscular anomaly, and because of that he's having a torticollis. So because he's continuously tilting on one side, and sometimes people have made mistakes in diagnosing as ocular torticollis, whereas it was not.
So one is that you should be able to differentiate the congenital versus the acquired by the fact that there would be a fusional divergence which is there. The fusional divergences would be much more. Vertical fusional divergences are increased in cases of congenital superoblique palsies. So if you see that, that will be an indicator of the fact. Secondly, if a person is complaining of torsion, then it is more likely to be an acquired. The congenital ones don't complain of torsion, even though they have an objective torsion, and even though they have a head posture to neutralize it, they are not aware of it most of the time because of the sensory adaptation that they have. So that is another thing which will be helping you out. And the older pictures, like the FAT scan, as it was mentioned in the video of Dr. Sumita, that older pictures will help us know if it's a congenital versus an acquired superoblique palsy. So you're right, just a history of trauma may not be necessarily the fact it may be a pre-existent congenital supraoblique palsy and the trauma may have been an incidental thing. So we need to distinguish that.
Yeah.
So if there are any
questions from any of the panelists?
From either the panelists would like to comment, they can also unmute themselves and come over it.
In a DRS, exo DRS with suppose there is a -2 abduction deficit, exo DRS with -2 abduction deficit and a -4 adduction deficit, and we got an MRI done and there was thinning of the medial rectus. So what is the surgical procedure? Would we still go ahead with lateral rectus periostal fixation, or in this case, because even the medial rectus, there is no adduction at all. So would you still go in for a lateral rectus periostal fixation, or I do a lateral rectus and along with that a VRT to the medial rectus?
Okay. So in this case, intraoperatively, Shuma, I think you would have to look for the force reduction test.
Yeah.
The medial rectus you're saying is fibrotic, but is it also having a limitation in abduction? Is it causing a limitation of abduction, or is it a peritic medial rectus? It's very unusual in DRS cases, usually exo DRS cases, to have a thinned out medial rectus. That would be something mixed with some other form of the spectrum of the CCDD.
CCDS, okay.
So it would be like synergistic divergence. Some people add the type 4 DRS as the synergistic divergence. So I think that we need to be careful about. So when we are doing these cases, then we would have to see the FDT intraoperatively.
If it is tight, then it would be better to do a...
If the lateral rectus is tight, then you would have to do a lateral rectus recession with a Y-split. And how is the upshoot and downshoot? How bad is that?
There's no upshoot and downshoot because the eye does not go in at all, like, you know. So
it might not be an actual DRS, but maybe more like a synergistic divergence.
Synergistic divergence splits out. Okay. So in that you would not, you don't prefer a lateral rectus periostal fixation. Yeah, I'm just.
Yeah, in synergistic divergence, one option is doing a lateral rectus periostal fixation, which we used to do earlier. Nowadays, once we are having this LR to MR transposition, that becomes a choice. But here you are saying DRS. I am little intrigued that does it have a...
Yeah, because there's no, the only thing is what I was like, there's no ptosis. And that's why even I was confused. There was no ptosis, and but there was got an MRI done. Medial rectus is hypoplastic, so it is like one of the CCDS variety. But I was wondering whether should I do a lateral rectal periostal fixation along with the VRT to MR, or should I do that by like splitting of the lateral rectus to medial rectus? I think that would be a better option, no?
It's a better option. So LR split to medial side would be a better option because it will take care of both the problems with just one muscle, the lateral rectus.
Okay.
But provided it is not an aberrant innervation like a DRS. So I don't think it's a DRS. Then you can go ahead with the LR to the...
Yeah, but there's no upshoot and downshoot, yeah.
So it would be then a synergistic divergence as a diagnosis. Right. I think Dr. Murli had presented very nicely the nystagmus cases, and he highlighted the points of if there is a mixed strabismus along with the nystagmus, how to tackle. I think that point needs to be once again emphasized, that you need to know which is the dominant eye in the cases of nystagmus, because whatever nystagmus surgery you would do would only be beneficial if you are operating on the dominant eye. And the other eye surgery would be done for the correction of the strabismus which is associated with it. And sometimes we have a paradoxic situation that the nystagmus surgery itself will increase the strabismus. If we have, let's say, an exo with a adduction null, then if we are going to do a recession of the medial rectus to correct the adduction null, you would be increasing the exo. So in such a situation, you may have to do a larger strabismus surgery on the north. Right? And the other point which he also highlighted was the mixing of the head postures. And that is another intriguing problem at times we have, that we have both a vertical as well as a horizontal abnormal head posture. And what he said is right, that we would correct the dominant head posture, which is more predominant first. And if necessary, only the other head posture may be corrected. Many a times we get away with the one particular surgery, and you may not have to do. The third thing which may be sometimes bothering you is the PAN, the periodic alternating null nystagmus cases, in which there is a variable head posture. So these are cases which you have to be very careful. You can easily miss PAN because there may be an asymmetric PAN. Then children may be having a predominantly one particular head posture, and you may do an augmented Anderson's procedure, and the next day you may be surprised to see the total shift of the head posture. So you are fortunate if you have done augmented Anderson's. You can easily do the other two yoke muscles and it will correct the PAN. But if you have happened to do a Kestenbaum procedure, you have to undo the resection also. So that is something which goes in favor of doing an augmented Anderson's as a primary choice whenever there is a 30 degrees of a null, eccentric null. So I think these are the points which I would like to make. If there is any other panelists would like to make any points, you're welcome.
Thank you, sir, for all the lovely. I mean, every time we hear from you, every time we get to learn something. It's so wonderful to hear from you.
It's very difficult to speak anything in front of you, sir, except for clarifying our own doubts.
Don't say that. Then I should be recusing myself.
So much to learn.
Yeah. It's a pleasure always.
Thank you, sir. Thank you. Thank you, all the speakers also. I learned a lot from all of you. Thank you.
Any additions, anything, Gurli, you would like to come?
No, sir. I mean, thank you always present in front of you. And every time I hear your talk, I learn something new from you.
Thanks, thank
you, sir.
So I think then we would be leaving before time if there are no questions, and we would like to thank all the panelists, especially the moderator and the team. Time details very, very strictly. Give us this extra time now that we can smile and laugh.
Thank you so much, sir. आपके बिना time पे नहीं चल पाता. Thank you so much. Thank you.
Thank you.
Yeah, thank you.
Thank you, Ron. Thank you, sir. Good night, sir.
Good night.
Tomorrow morning 9:30 we shall be getting started with our sessions. Thank you so much. Good night.
Good night.
Good night. Have a nice dinner. Bye bye.